Ma'am,
more
please start.
than half of your appetite, and that too once a week. And
Girija ma'am, you can start.
Girija ma'am, please start.
Yeah, thank you so much, ma'am. Thank you so much, sir. Good afternoon, one and all. Myself, Dr. Girija Thakur. I'm an ISC expert for SDSU team Maharashtra. On behalf of State TB Cell, I welcome to the all participants from the state and district branches of IIP. I also welcome to Pediatrics, State TB Cell authorities, WHO consultant, and State TB SDSU team members to this important sensitization meeting come webinar on the National TB Elimination Program. Of course, it's a collaboration with the Indian Academy of Pediatrics of Maharashtra. Today's panel discussion will focus on basically pediatric TB management and what are the NTEP guidelines regarding to that. So we will discuss on that. So before we start this meeting, I request respected Dr. Vasant Khadkar sir, National President of IIP, to share his opening remarks and guide us to how we move forward our discussion. Over to Dr. Vasant Khadkar sir.
Respected all, it's a really great pleasure to join on this event. I'm attending all the dignitaries who are attending, all the government officer, Dr. Girja, and our key person, and our Maharashtra IP President, Dr. Sanjay Pakmode, Secretary Dr. Amol, Dr. Shilpa, who is a pulmonologist and at present President of Nagpur IP. I welcome you all on behalf of Central IIP. It's really a noble project is going on, that is National Tuberculosis Elimination Program, and I am very much attached to this program since last at least 10 years. As far as this was beginning, because my one of my center hospital is the center for the collection and everything, and I had done a lot of work at the central level for this. But why? What is the need? Because as per the global TB report, India bears the highest burden of tuberculosis, which contribute 26% of the total global cases. There, it's a leading cause of death among infectious disease. We have seen it as per data in 2023. As in 2023, 3.15 lakhs people in India lost their lives due to TB. Our government has a targeted goal to so to have about tuberculosis, and that 5 years ahead of TB, that is 2030. Our target is to achieve the sustainable development like that SDG goal. So this includes an 80% reduction in TB incidence and 90% reduction in TB mortality and a 0% catastrophic cost for the patient. According to National Strategic Plan, in 2017-25, private sector segment is a crucial component in achieving TB elimination, as over 50% of TB cases are managed in the private sector. And this is really true fact. We are seeing more and more patients than government hospital. 50% is not a small figure, and if we lose these patients,
तुमका तेवढं कमाई होते आपल्याला.
yeah, somebody
डॉक्टराचं काम
please,
महत्वाचं आहे.
please unmute others.
Please mute.
काही
Please
डॉक्टर
mute.
कलेक्टर
So if we private practitioner will not take the advantage of the government scheme and we will not do doctor, again the same thing, same story is going to repeat. So please, that's why Maharashtra government and Maha-IP, always is a vibrant amongst all the states. That is, we are having a 47,000 members. Out of that, 5,500 members are from Maharashtra in Indian Academy of Pediatric, and that's to be Maha branch, really, literally number one branch. Having so many districts, at 38 districts we are having, and we are doing a lot of work in Maharashtra. Though I can't say for a single state, but I am really proud to be from Maharashtra, that's from Nagpur, and Maharashtra member. This really, because this chapter is really doing the great work. Now credit goes to definitely this year Dr. Sanjay Bagmode, Amol, and all the team. Last year also Dr. Chejara was there, and all the president of Maharashtra were working hard. So I assure government that IIP is always helpful, instrumental in doing awareness. Not only awareness, but to have a कंधे से कंधा लगे की जे काम करायचं म्हणतात ना, खांद्याला खांदा मिळून काम करायचं. वी आर ऑलवेज रेडी. आम्ही IIPN केव्हाही तयार असतो. तुम्ही फक्त ऑर्डर करा, तुम्हाला जेव्हा पाहिजे आहे तेव्हा. आणि आज वी वॉन्ट टू अचीव अवर गोल ऑफ SDG 2030. Whenever you will need anything from national, that is central IIP, I am available 24/7. So my soldiers of Maharashtra IP are with you. So I'm telling government that don't worry, we are always with you, and we will achieve goal of SDG 2030 definitely. Thank you once again for calling me. Thank you, and I wish all the best for this project. Thank you.
थँक्यू सो मच सर. इट्स अ ग्रेट वर्ड फॉर अस दॅट अगदी बरोबर बोललात की खांद्याला खांदा लावून जर चाललो तरच 2025चं जे गोल आहे किंवा SDGचं गोल आहे ते साध्य करायला निश्चितच मदत होईल. थँक्यू सो मच सर. नाऊ आय रिक्वेस्ट डॉक्टर संजय पाकमुडे सर, State President of IIP Maharashtra, provide his insights about today's meeting. Over to Dr. Sanjay Pakmude, sir.
Yeah, my video is not visible because of some connectivity issue. So good afternoon, respected Dr. Vasant sir, CIP President 2025, Dr. Amol Pawar, Executive Board Member, and as well as the Secretary MAHAIP, Dr. Jitu Gavane, and Dr. Sushant Mane, who is always means we are hearing as whenever there is a program of tuberculosis, the first name strikes to mind is Dr. Sushant Mane sir, who is working at present in JJ and project head for this particular program. Then Dr. our recently installed President Shilpa Hazare madam, who is a pulmonologist, and Yevle sir, State Technical Support Unit Leader, and Girija madam. So as sir has already said, we will have to work in unity, means because most of the patients are catered by the private practitioners. But when the treatment part comes, there is some problem, because what the strategy we have used, that is the fixed drug combinations, and to avoid the drug resistance, we need to follow certain principles. So as this national TB elimination program, which was initially the control program, then the revised national control program, and in 2020 it became the national elimination program. In this program, the particular strategies are put, and as in the program it has been said that we have to eliminate tuberculosis 5 years before the WHO plan of 2030, that is in 2025, and 80% reduction in the incidence and 90% reduction in the mortality. So to achieve this, we'll need a strategic planning, a very meticulous planning, as well as we'll have to work the government officials, those working in the as far as the in the TB, in the elimination of the TB is concerned, and as well as the private practitioners. And this type of panel discussions or workshops are going to help the private practitioners, so that many patients who come across them, they should not miss those cases of tuberculosis in detecting the cases. Then the second is the treatment of the, third is the prevention, and fourth is the build, which are the 4 pillars of National Tuberculosis Elimination Program. So I think this panel discussion is going to help all MAHA-IPNs for attending today's panel discussion. They will be helped, and in future also we will conduct such type of programs, so that many things which are not known to them with related to the national TB elimination program, they will come to know, and from the experts, they will be updated what is going on and what we have to do in future. Thank you. Thank you. Thanks.
Thank you so much, sir. As you rightly said about the 4 pillars of NTP, it's really very crucial. But yes, with your support and association support, we definitely do the best from for the Maharashtra. Actually, sir, Dr. Sandeep Sangle, sir, Joint Director of Health Services, State TB Office. He's very much interested to interact with you all, but due to some national level meeting, he is in travel today. But he shared his kind regards and thankful to the IIP Maharashtra for immense support. But now I request Dr. Nitin Bhalerao, sir, Additional Director of Health Services, State TB Cell, Maharashtra, to share his thoughts about NTP program and its objective.
सर्वांना नमस्कार. मी डॉक्टर नितीन भालेराव, सध्या असिस्टंट डायरेक्टर म्हणून स्टेट टीबी ऑफिसला कार्यरत आहे. सर्वात प्रथम या NTEP कारक आणि IIP यांच्या जॉईंट व्हेंचरने याचं पॅनल डिस्कशन तथा वर्कशॉप सुरू आहे. त्यासाठी आवर्जून उपस्थित असलेले डॉक्टर खळदकर सर, नॅशनल प्रेसिडेंट IIP, तसंच डॉक्टर पाकमोडे, स्टेट प्रेसिडेंट IIP, तसेच कार्यक्षेत्रामध्ये कार्यरत असलेले सर्व मान्यवर, डेलिगेट तथा पीडियाट्रिशियन या सर्वांचं मी स्टेट टीबी ऑफिस तर्फे स्वागत करू इच्छितो. तसं म्हटलं तर डॉक्टर खळदकर सरांनी आणि पाकमोडे सरांनी माझं अर्ध काम केलेलं आहे. तथापि जे काही आजच्या या पॅनल डिस्कशन तथा वर्कशॉपसाठी जे काही प्रोग्राम किंवा स्टेट कडून किंवा नॅशनल लेवलवर जे काही NTEPच्या अनुषंगाने जे पीडियाट्रिशियन कार्यक्षेत्रात कार्यरत आहेत, की जे आपल्या कार्यक्षेत्रातील आपल्या रुग्णांना, पेशंटला सेवा देत आहेत, त्याच्यामध्ये आणि नॅशनल प्रोग्राम्सच्या ज्या काही गाईडलाईन्स आहेत, तर त्याच्यामध्ये कुठेतरी कोलॅबोरेशन असावं, त्याच्यामध्ये सुसूत्रता असावी. आणि आता जे काही आपल्या इंडियाने TB फ्री इंडिया हा जो काही गोल सरकारने आपल्या पुढे ठेवलेला आहे, आणि त्याच्यामध्ये आता वेळोवेळी भरपूर चेंजेस होत आहेत आणि चेंजेस आपल्यापर्यंत पोहोचावे आणि त्या अनुषंगाने आपलंही त्याच्यामध्ये ऍक्टिव्ह पार्टिसिपेशन असावं. म्हणजे आपल्याकडे तो जुना कन्सेप्ट आहे पब्लिक हेल्थ प्रायव्हेट पार्टनरशिपचा, ज्याला आपण PP म्हणतो. तसं म्हटलं तर आपल्याकडे IMA म्हणा किंवा पीडियाट्रिशियनच्या याच्यामध्ये ऍक्टिव्ह सपोर्ट आपल्या सर्व संघटनेचा या ठिकाणी आतापर्यंत आलेला आहेच. आणि त्याचाच परिपाक म्हणायला हरकत नाही की आज महाराष्ट्रामध्ये आपण मागच्या वर्षी जवळजवळ 2,30,000 केसेस डायग्नोज केल्या, ट्रीटमेंटवर ठेवल्या, आणि त्याच्यामध्ये 11,000 प्लस ह्या पीडियाट्रिक्स केसेस आहेत, की जो नॅशनल लेवलच्या जवळपास आपण तेवढा महाराष्ट्राने अचीव केलेला आहे. आणि याच्यामध्ये माझं मत असं आहे की याच्यामध्ये प्रायव्हेट सेक्टरचं योगदान हे जास्त आहे. कारण की बराच प्रायव्हेट सेक्टरमध्ये पीडियाट्रिक्सचा जो काही पेशंट असेल तर त्याच्यामध्ये असलेले अफिनिटी आणि बाकीच्या सगळ्या इतर गोष्टीचा विचार करता आपल्याकडे त्या सर्वात प्रथम येत असतात. आणि हे सगळं करत असताना जे काही नॅशनल गाईडलाईन्स आहेत, नॅशनल स्ट्रॅटेजी आहे, तर त्याचा आणि याचा जर का आपल्याला योग्य रीतीने वापर करून ते जर का प्रॉपर इंटिग्रेटेड अप्रोचने जर का आपण कार्यरत केलं तर निश्चितच त्या आपल्या समोरच्या पेशंटला किंवा रुग्णांना किंवा आपण लाभार्थींना म्हणूया तर त्याचा फायदा होऊ शकतो. अलीकडेच गव्हर्नमेंट ऑफ इंडियाने जे काही असे TBचे रुग्ण आहेत त्यांच्यासाठी 1,000 रुपयेचं अनुदान त्याच्यासाठी जाहीर केलेलं आहे, की जे पूर्वी 500 रुपये होतं. ही माहिती सुद्धा आपल्याला माहीत असणं अपेक्षित आहे, किंवा त्या रुग्णांपर्यंत पैसे कसे पोहोचवले जातील, त्याचा त्यांना कसा उपयोग होऊ शकतो, ह्या सगळ्या बाबी ह्या ज्या काही नवीन आलेल्या ज्या काही गोष्टी आहेत हे आपल्यापर्यंत पोहोचाव्या. आपल्यासाठी सुद्धा काही थोड्याफार प्रमाणामध्ये सुद्धा गव्हर्नमेंटने अनुदान उपलब्ध करून दिलेलं आहे, ते आपल्या लोकांना माहीतच आहे, तरी पण त्याच्यामध्ये थोडंसं उहापोह व्हावं आणि अल्टिमेटली हा प्रोग्राम चांगल्या प्रकारे आपल्या महाराष्ट्रामध्ये राबवला जावा ही अपेक्षा आहे. तसं म्हटलं तर पीडियाट्रिक्सच्या TB हे डायग्नोज करणं, त्यांना ट्रीटमेंटवर घेणं किंवा बरं झाल्यानंतर सुद्धा त्याची योग्य ते काळजी घेणं हे त्या पालकाबरोबरच एक सिस्टीमला सुद्धा आणि पिडियाट्रिशियनला सुद्धा जसं एक चॅलेंज असतं. हे चॅलेंज आपण नेहमी स्वीकारतच असतो आणि आपण आपल्या रुग्णांना शक्य तेवढी मदत करण्याचा आपला ध्येय किंवा गोल असतोच. तर त्याच्यामध्येही अजून जास्त क्वालिटेटिव्ह आपण कसा अप्रोच असावा हाच उद्देश आजच्या या पॅनल डिस्कशनचा किंवा वर्कशॉपचा आहे. अपेक्षा आपल्याकडनं अशी आहे की याच्यामध्ये असले जे काही पर्स्पेक्टिव्ह किंवा काही सजेशन्स, जसं आता थोडंसं कळतकर सरांनी त्या विषयाला टच केलेलं आहे, तर याच्यामध्ये आपल्याकडनं कार्यक्षेत्रातनं आलं तर निश्चितच आम्ही आमच्या स्टेट कोऑर्डिनेशन कमिटी मीटिंगमध्ये म्हणा किंवा नॅशनल लेवलच्या जे काही प्लॅटफॉर्म असतं, फोरम असतं, तर त्याच्यामध्ये सुद्धा हा विचार आपण तुम्ही या ठिकाणी दिलात तर आम्ही त्यांच्यावर पोहोचण्याची आम्ही या ठिकाणी काळजी घेऊ की जेणेकरून अल्टिमेटली जो काही आपल्याला टीबी फ्री इंडिया हा जो काही आपला गोल आहे तर तो लवकरात लवकर सक्सेस होण्यासाठी आपली ही वाटचाल जी सुरू झालेली आहे तर त्याच्यामध्ये अधिक वेग येऊन आपण आपल्या महाराष्ट्राला त्याच्यानंतर आपल्या देशाला कसं टीबी मुक्त करू, हे जे स्वप्न आहे हे कसं पूर्ततेकडे जाईल याकडे आपण प्रत्येकाने खारुताईचा वाट्यासारखं आपण कॉन्ट्रीब्यूट केलं तर निश्चितच आपल्याला तो दिवस खूप लांब आहे असं वाटणार नाही आणि तो दिवस निश्चितच आपल्या वाट्याला येईल असं मी आपल्या सर्वांच्या सहकार्याने मी या ठिकाणी इच्छा बाळगतो, स्वप्न बाळगतो आणि पुढील जे काही आपल्याला डिस्कशन करायचं आहे, जे काही आपल्याला पुढचं जे काही वर्कशॉपचे जे काही सब्जेक्ट आहे त्याला सुरू करण्याची मी संयोजकांना विनंती करतो आणि आपल्या सगळ्यांना शुभेच्छा देतो. धन्यवाद.
थँक्यू सो मच सर. निश्चितच इंटिग्रेटेड अप्रोच जर असेल तर कामात सुसूत्रता यायला वेळ लागत नाही आणि तुम्ही दिलेल्या मार्गदर्शनाचे निश्चितच पालन होईल. थँक्यू सो मच. I request Dr. Amol Pawar sir, Secretary of IAP Maharashtra, to give instructions to the participant for this fruitful discussions today.
थँक्यू मॅडम. प्रथमतः मी गिरिजा ठाकूर मॅडमांचे खूप खूप आभार मानतो आणि त्यांना कॉंग्रॅच्युलेट करतो की त्यांच्या सर्वात महत्वाचं म्हणजे त्यांच्या मेहनतीने आज हा प्रोग्राम आपल्याला हे सर्व सेशन आपल्यासाठी आपण सादर करू शकलो. सर्वप्रथम डॉक्टर संदीप सांगळे सर इन इज ॲब्सेन्शिया, ही इज जॉईंट डायरेक्टर NTEP द स्टेट टीबी सेल. ऍडिशनल डायरेक्टर आत्ताच आपल्या सर्वांना मार्गदर्शन केलेले डॉक्टर नितीन भालेराव सर, आमचे IAP चे नॅशनल प्रेसिडेंट डॉक्टर वसंत खलटकर सर, स्टेट प्रेसिडेंट डॉक्टर संजय पाकमुडे सर, आजचे सर्व आपले पॅनलिस्ट डॉक्टर राजाभाऊ येवले सर, जे की मी बऱ्याच ग्रुप्स मध्ये बघतोय की राजाभाऊ येवले सर गेल्या महिन्याभरापासून IMA असो किंवा डिस्ट्रिक्ट लेवलचे जे IMA चे फंक्शन्स असो तिथं सर्व ते मार्गदर्शन करण्यासाठी नेहमी तत्पर असतात. तर राजाभाऊ येवले सर, डॉक्टर सुशांत माने, डॉक्टर अमोल मुरकुटे, डॉक्टर शिल्पा हजारे मॅम, डॉक्टर जितेंद्र गावणे सर, सर्व आजचे पॅनलिस्ट, या सर्वांचे मी खूप धन्यवाद मानतो की त्यांनी या कार्यक्रमाला येण्यासाठी अनुमती दिली आणि सर्व आजच्या या वेबिनारसाठी आवर्जून हजर असलेले आपले आजचे MMC ऑब्झर्वर डॉक्टर राजेंद्र कुलकर्णी सर, त्यांनाही मी वेलकम करतो. आणि आजच्या या वेबिनारला मोर दॅन 300 पेक्षा जास्त लोक जॉईन आहेत, जे की टीबीच्या संदर्भात सर्व जे ज्ञान आहे, पीडियाट्रिक ट्युबरक्युलोसिस साठी काय रिसेंट गाईडलाईन्स आहेत, काय आपले जे मान्यवर आहेत ते आपल्याला सांगणार. यासाठी महाराष्ट्रातून बरेचसे जे काही मेडिकल ऑफिसर्स, डिस्ट्रिक्ट टीबी डिपार्टमेंटचे बरेचसे मेडिकल ऑफिसर जॉईन आहेत. त्यांनाही मी धन्यवाद देतो की ते आवर्जून या कार्यक्रमाला उपस्थित आहेत. आता या बाबतीत सांगायचं झालं तर टीबी मुक्त व्हायचंय, आपल्या देशाला टीबी मुक्त करायचंय आणि यासाठी NTEP डिपार्टमेंट, नॅशनल लेवलला हेल्थ मिनिस्ट्री असो, स्टेट हेल्थ मिनिस्ट्री असो, सर्वजण आवर्जून प्रयत्न करतायत. आपल्याला सर्व माहिती माझ्या आधीच्या मान्यवर डॉक्टर वसंत खलटकर सर, पाकमुडे सर आणि आत्ताच नितीन भालेराव सरांनी विस्तृत अशी माहिती दिलेली आहे. तर मी NTEP डिपार्टमेंटचे खरंच आभार मानतो आणि पुढे पुढील कार्यक्रमासाठी डॉक्टर गिरिजा मॅडमांना विनंती करतो.
Thank you so much, sir. As it's a joint hands efforts, you also supported a lot to success this event. Thank you so much, sir. Now I request Dr. Rajabhau Yevle, Team Lead STSU Maharashtra, to facilitate the panel discussion. Dr. Yevle, sir, is a MD in Preventive and Social Medicine. He has worked as a WHO NTP medical consultant over 12 years with various states and having public health experience about 20 years. Currently, he is a leading state technical support unit team of Maharashtra to improve private sector engagement in NTP. Over to you, Dr. Yevle, sir.
Thank you, Girija. And really, it's heartening to see so many pediatricians have joined today's this panel discussions. Again, I welcome you all on behalf of State TV office. And I'd like to start this panel discussions. We have very eminent pediatricians or personalities to have this on these panels. So I'll briefly introduce them, and all of them are either they are from government medical college, private medical college, and some of them are practicing in a private hospital also. So we have a mixed group of experts to discuss about tuberculosis management, and also parallelly discuss about the NTP guidelines, how they are and how we are going to use it. And basically, objective of today's discussion is that only to update you all about the NTP guidelines, how TB is being managed, what is recommendations, and how it is actually being managed in private sector by the private pediatricians. So it is a joint discussions, and with this discussion, we can move further. So we have a very eminent personality for this panel discussion today, Dr. Sushant Mane. So I think he doesn't need any introduction for TB, at least in Maharashtra, because he is part of many expert panel at national level and even with the WHO for framing the guidelines on pediatrics. And currently he is associate professor and nodal officer for pediatrics in JJ Medical College, Mumbai. And he's actually nodal person for a center of excellence, which is a unique center in Maharashtra and India, which is dealing with especially for the pediatric MDR TB cases. So he is having a lot of experience on that. So both way in practical implementation and framing the national level TB guidelines. So he is very useful for today's session, and he has a lot of publications on tuberculosis. So next panelist for today's session is Dr. Silpa Hazare ma'am. She is a chief pulmonologist in Gateway Hospital Research Institute, Nagpur. Again, she is president-elect for 2025. He is part of various workshops, conferences as a faculty. Again, he's having a lot of publications, and her expertise is basically pediatric pulmonology, bronchoscopy, and interventions. We have Dr. Jitendra Gawane sir, who is a professor of pediatrics and PQ in charge in MJ Medical College, Navi Mumbai. In this medical college, we have a DRTB center also. So he is having experience of handling DRTB cases. And again, he is working in a private hospital, that is Rainbow Child Care Vasi in Navi Mumbai. So he will be able to share the private sector experience also. Again, he's having a lot of publications, and he's part of writing different books on pediatric tuberculosis and other aspects. Last one, young pediatricians, I can say, Dr. Dr. Murkute. He's a consultant pediatrician and director of Safalya Hospital for Children and Critical Care, Nasik. Again, he's assistant professor at Dr. Vasantrao Pawar Medical College Hospital and Research Center, Nasik. And he has also publications, and he's actively managing tuberculosis in private sectors. So with this mixed kind of group, definitely we'll get all the inputs, how TB guidelines are there under the National TB Elimination Program, and how it is being practiced in the private sector, and how the NTP services are being used in the private sector also. So before going into the actual discussions, I would like to show a few datas. Already we have discussed about that, but I'll just rush through that. So this shows, as per the Global Tuberculosis Report 2024, India contributes almost 1/4 of the global TB burden, and that's highest by any country. Even China contributes hardly 7% of TB disease globally. So considering this situation, our Honorable Prime Minister have given commitment to the global community that India will also follow these guidelines and align with the international goals of achieving SDG goals by 2030. So already we have discussed about first two components, incidence and mortality, but I would like to highlight on this reducing out-of-pocket expenditure. And this is one of the objective of these kind of sensitizations, that you all should try to use whatever free services available for diagnosis, treatment, and prevention under the program for the private sector patients also, so that we can reduce the out-of-pocket expenditure for all the patients. So as per this national strategic plan, the private sector engagement is one of the very crucial component for TB elimination, because almost more than 50% TB cases are being managed in the private sector. So that's why you all are very crucial for the TB elimination drive. And to achieve all those, to have a proper engagement with private sector, TB is already a notifiable disease in our country since 2012, and then in 2018, it is a part of our gazette. And as per this gazette, it is mandatory for every practitioners in public sector, private sector, even the chemists, to notify these TB cases. And if they fail to notify, there are some legal provisions also to initiate some actions. And at national level, as already Dr. Kalatkar sir mentioned, that IAP is very actively involved, and at national level, we have NTEP is having MOU with IMA and IAP to have a effective collaboration. And parallelly, even whenever private doctors notify the TB cases, we are providing incentives to them also. And there are in Maharashtra, in every district, we have a patient provider support agency to support the private practitioners for the notifying TB cases, collecting the samples from their hospitals to send it to the nearest CBNAT or TruNAT sites, providing the anti-TB drugs and adherence support. So these agencies are working in all the districts to support you all to have a better coordination between public and private sector. So what currently is going on because of a very active private sector engagement, you can see the progress in notification. In 2015, our TB notification was 16 lakh, and now it is almost 26 lakhs. So estimated number and actual notification number is now coming very close, and that all credit goes to active private sector involvement, and all of you are started notifying these TB cases. So in Maharashtra, if you see the contribution of private sector, almost now 50% cases are coming private sector. So in 2024, you can see that public sector notification was almost 1,16,000 and private sector is 1,13,000. So it is almost 50% you all are private sector is contributing. This was overall total data. For pediatric notification, this is now important for today's discussions, because if you see the India data as per the recent India TB report, in 2023, the pediatric TB cases notified in our country was 1,43,000, and it contributing almost 6%. But expected or estimated number of pediatric TB cases are almost 10 to 12% in our community. So there is a big gap in estimated number and actual notification of the TB cases of pediatric. Even if you see the Maharashtra data, in 2024, total TB notification was 2,30,000, and out of that, only 11,000 TB cases are pediatric. So it contributing around 5%. So almost we can say that 50% gap is there against the estimated number of TB cases in our country or in Maharashtra. And that's where we need a very active participation and support from all of you to diagnose these cases as early as possible and start notifying them. Even for the drug-resistant TB cases at India level, almost last year, 2,108 MDR TB cases were notified. Pre-XDR were 373, XDR 5, and H-mono 248. This is the national level data. Even in Maharashtra, almost 362 MDR TB cases were notified. So this was just a brief background to make you aware that what is current situation and what is the gravity of this problem and where we need to act on that. So now I'll start with the actual discussion of today's panel discussions. So we have all the panelists. So my first question will be with Dr. Sushant Mane because he's expert in all the things. So I would like to ask him and request him to update all about the NTP protocol on pediatric TB diagnosis and how TB, drug sensitive TB is being basically being managed. What are those guidelines? So basically, I have divided this session into three parts: drug sensitive TB, drug resistant TB, and then TB preventive treatment. So in first round, I would like to highlight on drug sensitive TB, how it is being diagnosed and managed as per the NTP protocol. So over to you, Dr. Suhan.
Yeah. Good afternoon, everyone, and thank you, Dr. Yevle, for that excellent start. So when we talk about tuberculosis as such, so we all know that tuberculosis affects each and every system of the body, right? But the primary system, what we look at when we talk about tuberculosis is our lungs. So if you see the data world over and even in India or our very own Maharashtra, and in pediatrics also, pulmonary TB is the commonest form of TB which we see in across all the ages. What happens in pediatrics is the proportion of extrapulmonary cases which are reported from the pediatric cohort are little higher as compared to the adult cohort. And then specifically to pediatrics, I don't know what is the general experience, but when we sit at referral centers, there is a third variety of TB. What we see is a disseminated TB. That means when more than two contiguous, more than one non-contiguous site is involved by TB, it is labeled as a disseminated TB. For example, when we have a pulmonary TB along with an abdomen focus or pulmonary TB with a CNS focus, we say it is a disseminated TB. So having got all these basics, okay, when we talk about pulmonary TB, the first, or for that matter, any TB, the first important thing what we must know is when do we suspect tuberculosis in any patient who walks to us. So when we talk about management, management starts with diagnosis, and diagnosis starts with how do we pick up the cases. So when any patient walks into our OPD, is brought to our OPD, when do we suspect tuberculosis? So then there are three basic criteria. First is fever, second is, so we are talking about pulmonary TB, second is cough, and third is failure to thrive or weight loss. So when we take these three symptoms, each of these symptoms has its own significance. When we say fever, the fever has to be documented at least once or twice. uh, the other causes of fever, that is, it should be an unexplained fever. Other causes of fever have to be ruled out. The common causes, like you have viral, you have malaria, typhoid, everything. Then, and the duration of symptoms should be going on for more than 2 weeks. Similar to fever, cough, any type of cough, whether it is a productive cough or non-productive cough, which is either persistent or worsening over a period of 2 weeks or more, we should suspect tuberculosis as one of the differentials. And third complaint would be either a loss of weight, a definite loss of weight. So if we have the previous weight records of the child, a loss of more than 5% of the child's weight over a span of 3 months, or in a child whose growth chart is adequately maintained, the child is not growing over a period of time. So failure to gain weight is also important. So if any one or more of these symptoms in combination are present, which are going on for a period of more than 2 weeks, we have to presume TB in such a kind of a patient. Now again, when I use the word, I said you should presume TB. So initially these kind of patients were called as TB suspects. Now the terminology has been changed to presumptive TB. Now the basic idea, because it is a big platform today and we are also talking from public health point of view, why this terminology change happened. This is very important concept. Now see, what was the what I can say, what was the magic mantra which led to eradication of polio? Okay, we got hands on with the AFP surveillance, that is acute flaccid paralysis surveillance, right? Any weakness occurring in any part of the body was reported. Just a facial palsy, just a monoparesis or a paraplegia, everything, every weakness was reported by the clinicians. Okay, then it was investigated whether it is polio or non-polio. What happened because of that? When we gathered all cases of flaccid paralysis, we could pick up more cases of polio. We could screen them, and then we could take public health measures. Similarly, when we report, or what we can say, when we presume TB in almost many number of cases with these kind of symptoms going on for more than 2 weeks, we are going to screen a whole lot of population, and in that we are going to pick up more and more TB cases. As we just saw, the detection gap of TB is 50% as far as pediatric TB is concerned. So the more we screen, the more we are going to get active cases. And therefore, suspect means what? There is a chance that it could be TB or it could not be TB. So for example, I would think this is TB. Somebody of you might not think this is TB. this is malignancy or this is something else. No. But what idea behind presumed TB is any symptom going on for more than 2 weeks, TB has to be kept as one of the differentials. Nobody is saying that you don't work up for other causes like a malignancy or autoimmune disorders or inflammation. Yes, you can do that, but keep TB as one of the differentials so that we get more and more number of cases. When we talk about extrapulmonary TB, this we are concentrating about pulmonary TB. Like we know, extrapulmonary TB affects any organ, CNS, heart, lymph nodes, abdomen, kidney, everything. The commonest extrapulmonary TB is a lymph node TB. Okay, so any swelling which is coming up inside, I mean, in any part of the body, most commonly the lymph node TB comes up in the cervical region, or maybe axillary region or inguinal region. Any long-standing symptom, a chronic low back pain. We have picked up so many of hot spine which are coming with a chronic low back pain or difficulty, sleeping in the night or night pain, something like that. If a CNS patient, which we are not getting any diagnosis, meningitis picture repeatedly on, CSF examination, not getting something. So basically, what we want to say is any long-standing symptom pertaining to any system, we should think TB as one of the diagnoses. Okay, so this is very important that you keep TB as one of the differentials. Once we have this clinical background in our minds that when do we presume TB in our patient, then as we want to know, once we have a diagnosis of TB, how do we go ahead or what do we do with the patient? So what happens with us is, like for example, if we take a pulmonary TB or any sort of TB, first as we saw, the clinical presentation is very much variable. Like you can imagine fever and cough. Okay, there could be at least 20 DDs in a child, or fever and weight loss, or fever and low back pain, or just a lymph node swelling. So the clinical features are a little bit confusing or overlapping. The second hurdle when it comes to pediatric TB diagnosis or picking up an accurate diagnosis is how do we get the sample? Now, imagine an adult patient who is having pulmonary TB, he is easily able to cough out sputum and we send it for our microbiological test, CBNAT or smear or culture, whatever. Now, children by and large who are less than 7 to 8 years of age are not able to expectorate out sputum. Sometimes we have seen even an older child, like a 10 or 11-year-old or 12-year-old, is not able to get out sputum. So then we have to resort to a semi-invasive method like a gastric aspirate. Okay, and therefore that brings us to the importance of learning the adequate, I mean, proper procedure of taking a gastric aspirate. So as we all are pediatricians here today, each and every one of us should be aware of the basic procedure how to take a gastric aspirate, because the quality of sample goes a long way in getting a positive result. We know that the disease is paucibacillary. However, whatever amount of sample we send, because the bacterial load is low, it is possible that the test can come negative. But then if you don't collect the sample properly in the first place, then almost always the test comes out to be negative. So that is another challenge, how to get a sample for pulmonary TB. And extra pulmonary, it is a different ball game altogether. When we talk about even just a lymph node TB, we have to go invasive, either an FNSE or a lymph node biopsy. Then when we talk about CNS, it is CSF examination, that is lumbar puncture we have to do. If you're talking about abdomen, we may have to do abdominal node biopsies or endoscopic biopsies, so on and so forth. So it is a difficult process. I mean, matter when we talk about EPTB. Then that is why what we say is, when we have a proper characterization of symptoms, like if the patient is fitting into a diagnosis of presumptive TB, then we after labeling the child as presumptive pulmonary TB, then we go one step ahead. So what does the program say is, once we have a presumptive pulmonary TB in mind, the next immediate step what we do is a chest X-ray. Okay, when we talk about pulmonary TB, and then on chest X-ray, there are three findings what we see on X-ray which are highly suggestive of TB. Okay, so if the chest X-ray shows mediastinal lymphadenopathy, that is either a paratracheal, what you can see on the screens, paratracheal lymphadenopathy or hilar lymphadenopathy, or a miliary picture on a chest X-ray, or maybe a fibrocavitary picture. So any one of these three pictures, if present in a case or a child who is having signs and symptoms of presumptive TB, this is highly suggestive of TB, and we should go ahead with our microbiological test. So with this background, let us go and see the algorithm of pulmonary TB one by one, which is I think the next slide. So once we know that algorithm, we know how to go ahead, and so sampling methods we have talked about, what sample we need to send. Before the algorithm, I will just tell you the test which we need to send. So once we have collected the sample, whether it is a self-expectorated sample or whether it is a gastric aspirate, and an X-ray test is done, the microbiological sample is first sent for a molecular test, which is a NAT. The NAT is nothing but nucleic acid amplification test. It is a PCR based test. So under the NTEP, the types of NATs which are available to us are two types. One is a CB-NAT, which is a completely automated system, and another is a true NAT, okay, which is a semi-automated system, or you can say a semi-automated system. And the third is a line probe assay. It is again a molecular test. We will see what it is. And next is the TB culture. Now, what is written MGIT, the full long form or the full form of it is Mycobacterial Growth Indicator Tube. It is a form of liquid culture which is used nowadays for culturing TB bacilli. So nowadays we are not using any solid cultures. Whatever cultures we are using are all liquid cultures. The golden question is, how many samples should a pediatrician or a treating doctor send to the lab when we want to diagnose TB, or when we're sending for diagnosis of TB? The answer is always two. Okay. For example, when we're taking a gastric aspirate, we take it in two tubes. The tubes which are used for collection are known as falcon tubes. They are conical tubes. The sample is taken into the falcon tube and sent to the lab for testing. So the reason for sending two samples is, as far as pediatrics is concerned, under the program, that is NTEP, three categories are considered as key populations. Key means very important populations. One is pediatrics, that is children up to 15 years of age. Then any patient who is HIV positive, whether it is child or adult, and an extra pulmonary TB sample. So whenever we talk about these three key populations, in addition to running a CB-NAT or a NAT, okay, the another sample which we send is mandatorily taken up for culture by the program, which does not happen in adults. In adults, what happens is, when we send a sputum sample, CB-NAT is run, smear is done. If CB-NAT and smear is negative, the sample does not go for culture. The algorithm stops there, which does not happen with pediatrics. Even if the CB-NAT or the smear is negative, the second sample which you are sending mandatorily is put to the culture by the lab. So what is CB-NAT? Okay, CB-NAT, like I said, it is a molecular test. It will give us two important facts. It will not only pick up whether the sample is containing MTB or not, but it will also tell us whether it is resistant to rifampicin and not. And it is a very highly sensitive test. Like, for example, if we remember our microbiology days, for a smear to be positive, we must have at least 10 to the power 5, 4 to 5 bacilli per ml of sputum. That is around 10,000 to 1 lakh bacilli per ml of sputum. That much load. And as we just saw, that pediatric TB is possibacillary, so we are not going to get that much load of bacilli. This is where the NATs help us, that even if the sample contain as low as 100 to 120 bacilli per ml of sample, your NAT is going to pick it up because it is picking up the DNA. So it is a very wonderful test, and a much more sensitive test as compared to a normal smear, and it will give faster results. Okay, once the sample, it is a completely automated system. Like we said, once the sample goes into the machine, at the end of 2 hours we get a complete report which tells us whether MTB is detected or not detected, and whether it is resistant to rifampicin or whether it is sensitive to rifampicin. The only what I can say negative point of NAT is, it should not be used as a follow-up test. That means you diagnose tuberculosis at baseline, you start the patient on treatment. Now at the end of 2 months, or maybe at the end of 6 months, you want to document that the person has turned microbiologically negative. There we are not supposed to use NAT. We use either a smear or a culture. The reason being, NAT is a molecular test. It picks up DNA. Even if the DNA of a dead bacillus, small amount of DNA, is present in our clinical sample, at the end of 2 months, NAT will flag a positive result. And that is why NAT is never used as a follow-up test. One more addition to the NAT, or I can say improvement to the NAT, is a NAT Ultra or a CB-NAT Ultra. The mechanism, the machinery, everything is exactly the same. The sensitivity is much higher. So as we saw, NAT can pick up around 100 to 120 bacilli per ml of sample. The test will be positive. A NAT Ultra or a CB-NAT Ultra will pick up as low as 12 to 14 bacilli per ml of sample. In fact, CB-NAT Ultra is even more sensitive than culture. We have seen places where CB-NAT Ultra is positive, but the culture is negative. Okay, because for culture to be positive, the minimum load is around 20 to 50 bacilli per ml of this, and for NAT Ultra, it is around 12 to 14. So this test is advantageous when we talk about precious samples. For example, extrapulmonary samples like a lymph node biopsy, or a CSF, or a pleural fluid, or a ascitic fluid, where we want a little higher sensitivity test to pick up the disease, to have a microbiology positive test. Another advancement to CB-NAT is something known as expert XDR. Now, what is XDR is, so once the patient, or the sample is positive for rifampicin resistance, that means on a NAT or a CB-NAT, MTB is detected and rifampicin resistance is detected. The sample is run with an expert XDR cartridge that gives us information about resistance to additional drugs. So our CB-NAT gives us resistance to only rifampicin. Expert Ultra is going to give us resistance to additional drugs like isoniazid, ethionamide, the injectable drugs like amikacin, kanamycin, and also the quinolones like levoflox and moxifloxacin. Again, a very good test. Right now, not available through the program, but yes, it is freely available in accredited labs, private labs. And clinicians, if they are suspecting drug resistant tuberculosis and they really want to know the complete the resistance profile of the patient, it is a good test to be used. There are certain reasons why it is not yet uh, included into the program. TrueNat is nothing but an Indian counterpart of CBNat. So it is a indigenously developed test by an Indian company under the Prime Minister's vision of Atmanirbhar Bharat. The machine, the mechanism and exactly is same, and we get the same results of rifampicin sensitivity or resistant in 2 to 3 hours. And in fact, TrueNat is a less demanding machine. That means it does not require a very big lab setup. Like for example, a CBNat or a CBNat Ultra machine requires a biosafety level 2 or 3 lab, air conditioning, generators, continuous power supply, everything. TrueNat does not require anything. It comes in a handheld bag kind of a case. It is a battery operated machine. So even in places where we don't have electricity, the machine can run. Government of India has placed more than, I think, 4,000 TrueNat machines all over the country, especially at the sub-center levels and district levels. So even at the remotest of the places, now India is offering upfront molecular test for diagnosis of TB. And smear is not the first test. The smear is done alongside NAT, but the first test is offered is a molecular test. When we talk about line probe assays, so if a smear comes out to be positive, like I said, in addition to NAT, parallelly a smear is also run. If the smear comes out to be positive in a case of pulmonary TB, we have another molecular test which is known as a line probe assay, which we can do it on a positive smear, and we get resistance to not only rifampicin and isoniazid, which is known as a first line LPA, but we get resistance to the second line drugs like amikacin, kanamycin, and quinolones, which is a second line LPA. The only problem with this test is a smear has to be positive for this test to be run immediately after a CBNAT, right? If the smear is negative, what is done is, like we said, the second sample goes for culture. Once the culture grows positive or the culture flags positive, on that positive growth, we can do a LPA. So that is known as an indirect LPA. So for us, that is pediatricians, LPA does not help much because most of our samples are smear negative. Except for example, when we are dealing with adolescents, like 14 to 18-year age group, where they have the adult type of tuberculosis, pulmonary TB, where there are cavitations or fibrosis and all, where the bacterial load is high, there maybe the line probe assay helps us. But again, a word of caution is it does not replace the culture. Okay, sample has to go for culture. Okay, there is no question that each and every patient, one sample has to go for liquid culture. Now, what happens in liquid culture is the advantages of liquid culture is, so if it is positive, you have a confirmed diagnosis because when the bacteria are growing and we are culturing and we get a positive report, it is an active TB. Now, the advantage of culture is one, like we said, if we look at LPA or even if we look at XDR, there is only a certain set of drugs to which we get the resistance pattern. Quinolones, injectables. When we talk about diagnosis of drug resistant TB, there are 15 molecules or drugs which are available for treatment of drug resistant TB. So we don't have any molecular test, okay, for pretomanid. We don't have for linezolid. Okay, we don't have for PAS. We don't have for clofazimine. So these drugs, the sensitivity or the drug susceptibility test can be done when a culture is positive for all these drugs. So that is one advantage of culture. Second advantage, as we know, if CBNAT is negative, culture can be positive. So culture is again very important. Third, and another advantage is for follow-up. Like I said, follow-up, we don't use molecular test. Follow-up is the culture. So if we see our program algorithms, whether it is drug sensitive or drug resistant TB, at the end of 2 months for a drug sensitive, or maybe at the end of 3 months for a DRTB, we send cultures of the patient. For DRTB, we are sending cultures every month, third month, fourth month, fifth month, sixth month, and we see if they are negative or not. So follow-up documentation of microbiological conversion, cultures are important. And last but not the least, for small amount of patients where they might actually not have M tuberculosis, but may have non-tuberculous mycobacteria. Now, this is a very small genre as far as pediatrics is concerned. Adults, yes, adult chest physicians are seeing more and more cases of non-tuberculous mycobacteria being reported. In pediatric, right now, it is very much restricted phenomenon, that is the NTMs, and we basically see or commonly in children who are immunocompromised, like HIV positive kids or children who are having primary immunodeficiencies. There we could pick up NTM. So culture gives us an advantage of picking up non-tuberculous mycobacteria. So when we send the sample to the lab, and the sample is positive with any of these tests which we just saw, it is labeled as a microbiologically confirmed tuberculosis. So it is a confirmed diagnosis. So as you see, the first test which is offered is a NAT because it is a fastest test which gives result in 2 to 3 hours. Then is an LPA which gives results in probably 2 to 3 days. Then you have a liquid culture with the LPA done on the culture which will give you result in 2 to 4 weeks. And last but not the least, we have an LPA with a traditional drug susceptibility testing where the culture may take 3 to 4 weeks or maybe 5 weeks and 1 week to 10 days for the DST. So this is the gamut of tests which the NTEP is offering to each and every patient of presumptive TB. And mind you, all of these tests are offered free of cost under the program. The patient does not have to pay any of the cost for all these tests. Samplings we have discussed. I would just want to highlight here the third part. If you see, there is certain words written as bronchoscopy or IBUS or something like that. Now I get queries quite a lot amount of times that we did a gastric aspirate, it has come out to be negative. Should we do a bronchoscopy? So the standing message is bronchoscopy is not the answer for each and every patient. First and foremost, the thing is whether it was really a case of TB, whether it fit into the diagnosis of presumptive TB, number one. Second, was the X-ray suggestive of TB? With these two conditions satisfied, third and the most important thing, was the gastric aspirate collected in the proper technique? Fourth thing, after collection, did it reach the lab in time? That is standard time. It is said it should reach the lab within 4 to 6 hours. If you're not able to reach the lab, you have to refrigerate the sample and then send a sample. So all these things matter a lot when we say that the report is negative. I see so many doctors easily labeling that lab is not good, lab is giving negative results. No. So did we follow all these protocols? Did we have a clinical diagnosis of TB first? If it is not looking like TB, you are sending gastric aspirates in a normal X-ray, it is going to come negative. There is no chance that it will come positive, and then such patients are unnecessarily subjected for bronchoscopy. So bronchoscopy, in fact, there are at least 7 to 8 papers which have compared gastric aspirate and bronchoscopy, and they have seen that a properly collected gastric aspirate is as good as bronchoscopy. So I am not against bronchoscopy. In our center, we do bronchoscopies, but bronchoscopy being done for sampling of TB is very less. We do bronchoscopies for other indications. A very small amount of patients, we would actually do bronchoscopy for collection of samples. Then with this background, we will first go to the algorithm of pulmonary TB, and then we can, I think, come back to the treatment. That is the treatment of drugs.
Okay. Algorithm slide is not there in this.
Okay. So what I will just tell you in short is, so once you have a presumptive TB, you have any one of these X-ray findings, okay, that is a lymph node or a miliary or a fibrocavitary, the first thing you do is send a sputum or a gastric aspirate for NAT. If the NAT is positive, our life is easy. We have got a confirmatory diagnosis. Depending upon whether it is drug sensitive or drug resistant, we would be giving appropriate treatment. Now, sometimes if the NAT comes out to be negative, now you see the scenario is the case is the child is having or fitting into the clinical diagnosis of presumptive TB. He has one of these X-ray findings which are highly suggestive of TB, and still the NAT has come negative. In such cases, we give a benefit of doubt that maybe the sample was not collected properly or we have missed something. We will repeat one more NAT. Now, the second repeat NAT could be either the same, that is sputum or gastric aspirate, or if on clinical examination we find significant cervical lymph nodes or axillary lymph nodes, we can take a biopsy of that nodes, right? And we can take sample and send that. Once the second sample is sent, if the second NAT comes positive, again we are in a good place. That means we have a positive report and we are confirmed that is a diagnosis of TB. Now, if the second NAT also comes negative, okay, in such cases, we can label this patient as a clinically diagnosed case of pulmonary tuberculosis, and we are justified in starting treatment, first line treatment of drug sensitive TB. So the message here is very clear. Even if we have a classical presumptive case of TB, don't jump and start AKT at the first. Even if we have an X-ray which is highly suggestive like a cavity, don't jump and start anti-tuberculosis treatment just like that. Make every attempt to have a microbiological diagnosis. Even after 2 properly made attempts, the NAT or the molecular test is coming negative, then we can't wait because the X-ray is highly suggestive. It is clinically fitting into the diagnosis. We start the patient on treatment for drug sensitive TB and wait for our culture reports. So that is one possibility. Now, second possibility could be patient is fitting into a presumptive case of TB, that is fever or weight loss or cough, whatever, but the X-ray is not highly suggestive. Highly suggestive means the three pictures what we just saw on our screens. So TB patients can present only with pleural effusion. They can present with just a consolidation or just bronchopneumonia kind of a picture, anything. So these are not highly suggestive, because this could be TB or it could be any other bacterial or viral parasite or viral organism which is giving rise to this picture. What do the guidelines say is, when such a non-specific X-ray is present, then first what we see is, if has the child been given a course of appropriate antibiotic for bacterial pneumonia. If not, we give a course of appropriate antibiotic covering bacterial pneumonia for a period of 7 to 10 days. Now, which antibiotic do we use? We either use amoxicillin or amoxiclav. Apart from that, it is not advisable to use any antibiotics, because most of the other antibiotics like quinolones or linezolid are actually second line drugs for MDR-TB. So we don't use that. Even after a course of appropriate antibiotics for 7 to 10 days, the patient is still clinically symptomatic, the X-ray is still persistent. That is the time we are taking a sample for CB-NAT, whether it is a gastric aspirate or a sputum sample for CB-NAT, and then the algorithm will follow. As we just discussed, depending upon the NAT positivity or negativity, we would go ahead with the algorithm. In any case, whenever we are diagnosing tuberculosis, whether it is pulmonary or extrapulmonary, HIV testing has to be done mandatorily for all the patients. So this is an unsaid program. So there is a parallel consensus between the NTEP and the NACO, that is National AIDS Control. So any patient in whom we diagnose TB, you have to do HIV test. Any patient in whom we pick up HIV first, we have to screen for TB. So it is a parallel program, so it goes unsaid. So once we have a diagnosis, now suppose we get a positive test and we have a drug sensitive TB. Now, as per the recent guidelines, there is only one uniform therapy for drug sensitive TB, that is a 6 months therapy, 2 months of intensive phase, 4 drugs, HRZE, after which 4 months of continuation phase with 3 drugs, that is HRNE, that is ethambutol. Whatever may be the tuberculosis, whether it is pulmonary TB, whether it is extrapulmonary TB, microbiologically diagnosed, clinically diagnosed, if it is a defaulter patient, relapsed patient, lost to follow-up patient, in any of the scenarios, if it is a drug sensitive TB, we would be treating with 6 months of regimen, 2 months of intensive phase and 4 months of continuation phase. If we are having a neuro TB, or that is a CNS TB or a spinal TB, only in these two situations we would be extending the continuation phase for, instead of 4 months, we are going to give it for 8 you can say 9 to 12 months. So total duration is 12 months. So the continuation phase is 10 months. So 2 months of intensive phase and 10 months of continuation phase. The streptomycin is not there in the guidelines. So initially, if we remember, we had categories, category 1, 2, 3, 4. So category 2, so all those relapse or the defaulters used to put in category 2, where we used to add streptomycin. Now streptomycin is out of the program. There are only two categories, drug sensitive and drug resistant. Streptomycin has a very small role in the program, that too depending upon the case to case basis for certain cases of CNS TB. Otherwise, we are not advocating streptomycin to be used for any of the patients of drug sensitive TB, or for that matter, drug resistant TB. I think that covers the management. And yeah, doses. Sorry, I didn't talk about the doses. So as you see, always it is advisable to use the FDCs. FDCs are the fixed drug combinations. Okay, loose drugs we do not use. FDCs are available free of cost under the program, and all of these FDCs are very good quality drugs. The beauty of FDCs is the ease of administration. Now, if you see, if a child is a 14 kg child, you just see the table in front of you. 12 to 15 is the weight band. You give 3 pediatric tablets and 3 ethambutol tablets, and these tablets are dispersible. That means you put the tablet in half a glass of water or orange juice or something like that, and they dissolve instantaneously within 45 seconds to 1 minute, and the child can just gulp the fluid. So it is the ease of administration of these tablets, and the concentration, like for example, isoniazid is 50 milligram, rifampicin is 75, pyrazimab is 150, and then the weight bands are made. So if we follow these weight bands, there is no way that the child will get inadequate dose or underdosed. Okay, sometimes at the lower end of the weight bands, some children may get an extra dose, but that is okay, that is not a problem. But the child will never get underdosed. The only thing is, ethambutol is a separate tablet. You have to give it as a separate additional tablet, because it is not a dispersible tablet. In adults, we have the benefit that even the entire adult formulation is a dispersible formulation. So wherever possible, try not to use loose tablets, and it is not advocated under any guidelines. Not only Indian, but even the WHO says we can comfortably use FDCs.
Yes. Thank you, Dr. Sushant. I think you have covered in detail all diagnosis of TB and treatment of drug-sensitive TB, because that was very important to appraise all the pediatricians, what are the protocols, because drug-sensitive TB almost constitutes 95% of our TB, and that's the major thing, and that's why we have given more time. For diagnosis, definitely in program, these NAT technologies are available almost every rural hospital up to block level. So in Maharashtra, we have 171 CBNAT machines and 624 TrueNAT machines. So, and these facilities are available free of charge for public sector patients and private sector patients. And even the drugs are also available free of charge to the private sector patient. So moving to the next questions, basically now I want to have a private sector perspectives. So my next question will be to Dr. Silpa Hazare ma'am. What challenges you face in pediatric TB diagnosis, especially pulmonary TB in private sector? And what support you are taking from the NTEP for the diagnosis of TB? So your perspectives currently.
Thank you, Dr. Yevle. Actually, I would like to tell that, like as Dr. Sushant Mane has told, that we just generally uh, uh, make as per definition, we select the cases where the presumptive diagnosis of TB is fulfilled. And on those, the first test what we do is X-ray chest. And if the X-ray chest is TB suggestive, then only we do further investigation in those patients. Otherwise, if the X-ray test is not TB suggestive, then we try and give a antibiotic trial for 7 to 10 days and ask the child to follow up. Now, once we have identified a presumptive case, and if the X-ray test is TB suggestive, the next test is basically gastric aspirate or gastric lavage in children who are less than 10 to 12 years of age. And if the children are more than 10 to 12 years of age, who can bring out the sputum, or we can do a induced sputum, in them we ask for a expectorated sputum sample. Now, as far as gastric aspirate and gastric lavage is concerned, it is always preferred that it should be early morning, like once the child has woken up. If at that time, if we take a gastric aspirate or gastric lavage, that sample is definitely having more significant bacillary load, and that is the best sample. But many times in private practice, it becomes very difficult. So whenever the patient comes, we do gastric aspirate or gastric lavage, and that is the first sample what we said, that is the sample we send to the government centers only. Ours is a nodal center, so we are getting good support from government centers, that a person comes like whenever we ask, is within 2 hours. By and large, our samples are picked up from our hospital, and they reach before 4 hours to the center where the testing is done. So as far as that thing is, we are getting a good support from government. The reporting of the sample is getting quite late at my center. It's almost the reports come after 5 to 7 days after the sample is been sent. So that is one issue what we have. The next thing is, actually many times we do 2 or 3 times gastric aspirate, and if the gastric aspirate is coming negative, but the X-ray is TB suggestive, the child is fulfilling the presumptive case criteria. In that case, we try and see other samples. So the next thing what we do is, we always search for if there are any lymph nodes, because many times they may have few lymph nodes, so we have to search for lymph nodes, because it is very easy to do a FNAC or a excision biopsy, and that is a very good sample which we can send for CBNAT to GUM. So we send that sample to government centers for CBNAT basically. If I have had cases like I'll slightly differ from Dr. Sushant Mane as far as bronchoscopy is concerned, because I have had quite a few cases where gastric aspirate and gastric lavage was negative. The case was a fibrocavitatory case. There was a cavity within consolidation. It was treated outside before that child came to me for almost 1.5 months with multiple antibiotics, and in spite of that, consolidation was not disappearing. So we did a CT of that child. So there was a cavity within consolidation. We ourselves did gastric aspirate, but the gastric aspirate came as negative, and so we did bronchoscopy of this child, and there was a florid endobronchial TB to that child. So like this, we have had at least 4 or 5 more patients where after bronchoscopy we have detected that they have a endobronchial involvement, and then altogether the treatment changes, because if it is endobronchial TB, we have to add steroid also along with anti-tubercular treatment. So I think that of course it's bronchoscopy is not needed routinely, but in few patients we should be actually thinking of bronchoscopy, especially in pulmonary TB cases, or frankly disseminated cases where I think we should be thinking of bronchoscopy, because I have, what is my experience is that the sensitivity of CBNAT positivity in BAL was more compared to gastric aspirate in pediatric age group. I'm not aware of adult age. Maybe what paper Dr. Mane was talking, I think that paper must be of adult. I want to know from him later. But as far as pediatric patients, we have had many cases like this, that gastric aspirate, in spite of sending it properly, it was negative, and then bronchoscope bowel sample, it was strongly positive. So whenever we are sending sample, we are sending two samples. It's very important that we have to send a sample. We send for everything. We ask for CBNAT, we ask for LPA, and we ask for MGIT culture. So all three you have to send, because sometimes it happens that your CBNAT is negative, but the culture is later on positive. So because pediatric is a paucibacillary TB, we in fact face lot of problems. We have lot of challenges in diagnosing them, and that is a reason that there are many clinically diagnosed TB in pediatric age group. And somehow I think we have to work out for some strategy that how to reduce that component of clinically diagnosed TB, and how to increase the number of microbiologically proven TB. Of course, again, what I see is that we are not managing DRTB patients in our center. But if there are so much of DRTB in adults, there must be a significant proportion in pediatric age group also. But what we see the data, there is a significant difference in pediatric DRTB cases and adult TB cases. So that means probably we are definitely missing few patients, and so we have to work towards that. That is what I feel. One more issue what I want to specifically comment here is that we don't do much Mantoux tests nowadays. And our first tests are these, that first we do X-ray, we do hemogram and ESR, we do HIV testing because we want to know the status of HIV. And as per NTEP, we have to do HIV. Then we send the gastric aspirate sample for CBNAT and LPA and culture, MGIT culture. And if needed in that, sometimes if we needed, we do lymph node FNACs and biopsies. And after that, if we still strongly feel, we go ahead for bronchoscopy. many times, like what I feel is that Mantu, I get many patients where children have started ATT on the basis of Mantu positivity, and nothing else. The X-ray is not TB suggestive, but because Mantu is positive, the child is being treated for ATT. So I think that clarity has to be given to all the pediatricians that Mantu positivity just tells that it is the child is just sensitized to TB mycobacteria, and the child does not have disease. So just on the basis of Mantu positivity, actually we cannot label the child as TB. So that in fact in the algorithm does not even come. So I think that it is very important to show that algorithm that Mantu test is not there. Many times Mantu, you are supposed to give just 2 TU units of Mantu when you are doing the Mantu test also, if you want to know the sensitization. But many times it is 5, some gives 5, some give even 8. And if you are giving, if you are using more than 2 TU units, you are bound to get Mantu positivity. And you can have a few very malnourished children where even if you give 8 TU units, it is going to come negative. So it does not have much relevance. So that, I think, message what I want to give through this program.
Yes, ma'am. Very well said, and definitely diagnosing pediatric TB is challenging, and we need to use all different modalities available and whatever recent advances. Definitely on Mantus, I'll come to that question subsequently. But before that, I'd like to go to Dr. Jitendra Gawane, sir, to talk about what are your experiences about diagnosing extrapulmonary TB in pediatric. That's definitely a big topic, but briefly,
Right.
how
I
we
will
can
try to.
cover it. And
Right.
just
So,
one instructions to all participants that if you have any questions, just put it in chat box. We'll take it at the end of session.
yeah.
Yes, sir.
Thank you, Evle sir. Thank you, Maharashtra IIP, Akmode sir and Amol sir for giving opportunity. Now coming to extrapulmonary tuberculosis, diagnosing pulmonary tuberculosis also is a challenging because of paucibacillary nature of the disease, and to add the problems to us, extrapulmonary is still more difficult to diagnose. And as Shilpa said, we are now strict about reducing the number of presumptive diagnoses without any microbiological evidence to start AKT without any experts involvement in that. So extrapulmonary burden, Sushant was telling, it is more than adults. In children it is more. So almost 15 to 20% of the all pediatric cases of TB are extrapulmonary in nature. Most commonest of them is a lymph node tuberculosis. Almost 60% of the cases are lymph node tuberculosis, and that is one good point because we can access the lymph node to diagnose it. Abdominal is the next common, around 20%. Then CNS, which is very common in our practice. We get TB meningitis, tuberculomas, infarcts are around 10% of the total burden of the TB in pediatric age group, and then less than 5% will be the bone, joint, spine, and other like skin and uveitis. All those things will be very less common. The clinical presentation of extrapulmonary will be add-on to the previous constitutional symptoms like fever going for longer time and cough and weight loss, child not gaining weight. All these are important things. But on top of that, there will be organ-specific symptoms and signs like if he is having a TB meningitis, then obviously there's meningeal signs and history of fever and then headache and then projectile vomiting, the convulsions, all those things which are marking towards the system involvement also will be there. If someone is having a low back pain and fever running and weight loss, then obviously we have to think of some spinal TB coming up. So the clinical presentation on top of normal constitutional symptoms, we will have organ specific symptoms as well. The lymph node coming up and which is not regressing with the course of antibiotic also is a we have to think of the tuberculosis. Now coming to the diagnosis, it is very, very difficult to diagnose extrapulmonary cases. The inherent nature of the pediatric TB is a paucibacillary in nature. The facilities to obtain the microbiological culture microbiological sample from extrapulmonary sites is very difficult. As Shilpa was saying, she's in a center where she can readily do the bronchoscopy and get the scooping and diagnose the endobronchial tuberculosis very easily. But other places, it is not that easy to get a correct sample, abdominal TB or even TB meningitis, not very easy to get the what we say representative sample for sending for the CBNAT. Okay, the CBNAT also has a low sensitivity if we are sending the sample apart from the respiratory sample. So pericardial, ascitic fluid, synovial fluid are inherently low sensitive if CBNAT is done, and pleural effusion kind of things are almost never we get CBNAT positive in them. Fortunately, many of the times in TB meningitis we get CSF CBNAT positivity. So that is one good thing. So there are difficulties in diagnosing the extrapulmonary tuberculosis because of paucibacillary nature, obtaining sample of what we say, if we are planning the excision biopsy, the surgeon is not available, or if there are necrotic lymph nodes in the GI, then the CT guided or biopsy, no one is planning to do. Those things are practical issues about diagnosing the extrapulmonary TB. Coming to the TB meningitis, which is very common for all of us in pediatric age group, there are like cases where CBNAT of the CSF we are sending to the center, or we get negative result, and our clinical diagnosis or clinical acumen is telling that it is a tuberculous meningitis. TB or not to be is a question. Such questions when come, we don't think of Shakespeare, but I think of Sushant and just give a call to Sushant ki baba kya karne ka hai iska. So Sushant is readily available for me, and that helps me a lot of the times. And in TB diagnosis, there are now defined criteria when the CSF CBNAT is negative or the other samples are negative. So criteria 1 and criteria 2 and criteria 3. So the criteria 1 is when the clinical symptoms are more than 5 days, the WBC counts less than 15,000, CSF is showing the lymphocytic predominance, the CSF sugar is CSF to blood sugar level ratio is less than 50, or proteins are high. Obviously, we are thinking of TB meningitis, or CT or MRI is showing some infarcts or basal exudates, or the hydrocephalus coming up, or infarcts are there. Then definitely these form in criteria 1. The criteria 2 is when there are high risk categories, like the person or the child is HIV positive, he's an immunocompromised child, he's a SAM child, or he is having an active contact in the family who is having the active disease. Then that's we are calling into category, so criteria 2. And the third criteria is if this child only has a evidence of TB elsewhere in the body, then definitely that is also we are taking into consideration. So more than 2 clinical criteria are there, then the possibility of TB meningitis we are thinking as very high. So in such cases, obviously with the experts' opinion also should be taken for starting, because as Sushant said, only these 2 diseases like TB meningitis and osteoarticular TB or pot spine requires a longer duration of therapy, almost to 12 months. And before starting, we have to be very sure that our diagnosis is TB meningitis only. So in one of the case I remember, Sushant, you must be remembering, the CT was showing the typical picture of TBM was there. The CT was showing infarcts, and there were some minimum basal exudate, but CSF CBNAT was negative. 2 times samples were negative.
We started the treatment.
Yeah, we started the treatment on Sushant's advice, and Sushant advised to do CBNAT ultra on the CSF, and we clicked it, and the diagnosis was TB meningitis. So we were very confident after that. So to conclude in about extrapulmonary tuberculosis is a significant health problem in pediatrics. We need to start the therapy early. So all life-threatening diseases like tuberculosis, meningitis, and all, which will give either mortality or morbidity, and the attempts should be always made to microbiologically diagnose these kind of cases. Yeah.
Yes, very true.
Yes.
Yeah.
want to comment one thing. Actually, there are a lot of experts sitting here, Dr. Sushant Mane and others also. What is my experience is that many times in CNS TB or in disseminated cases, like we have had few disseminated cases where CSF was CBNAT was negative. But when we had done fundoscopy of those children, we found tubercles on retina. So how almost all these disseminated cases and many of those CNS TB cases, these tubercles were seen on the retina. So I want to ask, I think we should include that also as one of the investigations, because if it is positive, then it becomes more stronger case if the CBNAT is positive. So I actually want you all to give what you feel.
So in CNS TB, almost we have done a study also. Almost 50% of the patients, when we do a fundoscopy, we have choroid tubercles. So we have seen in cases of CNS TB. So there it does not matter so much, because as it is we are going to give treatment for 1 year. So it will take care of the choroid tubercles, and we also give steroids, because CNS TB steroid is one of the indications, so it does not matter. The problem arises in cases of disseminated TB. So, like for example, miliary TB, X-ray chest is showing a miliary picture, and in few cases, because of some other reason, we have done a fundoscopy, and in some patients there were choroid tubercles. So then, like Dr. Shilpa said, if you have the facility or ophthalmologist, CNS to we definitely do, because we look for papilledema and fundus. But if you have a miliary kind of picture on X-ray, always better to do a fundoscopy and get an ophthalmologist involved. The only thing is, it may not actually change the treatment, but sometimes what happens once we start the treatment, because of the immune reaction, the child may have blackouts or vision issues because there were tubercles there, and therefore it is very good to counsel the parents beforehand, that this certain things can happen because the child has choroid tubercles. And if the tubercles are really large, we may even consider very low dose steroids for the initial 2 weeks, so that the vision problems do not occur. So in
My
some cases,
question was that can we include this as an investigation? Like how much importance can we give to fundoscopy?
so that is what I said, wherever it is available, we can use it. At national program level, it is very difficult to include in guidelines, because at PSC level or sub-center level, we don't get an ophthalmologist. So, but like we said, if we are in a city place or place where we have an ophthalmologist, as clinicians, we should definitely do it.
Yes, yes.
Thank you.
It's good to hear the expert opinion on that. But definitely for this pediatric TB diagnosis, there are very structured guidelines available under this pediatric TB guidance document of 2022. And even one ICMR flyer where these guidelines are quite well laid down. So you can refer those things. So now, because we are running short of time, and I'll request Dr. Amol Pawar, can we overshoot the time, because we have to cover a lot of things, but we'll try to other those timings. Okay. So now next question to Dr. Amol Murkute sir. How you are treating drug sensitive TB in your private practice? What are regimen use? What Dr. Sushant have mentioned are the same regimen use, duration, and are you using NTP made available FDC drugs, and how's your experience about that?
So as far as managing drug-sensitive tuberculosis is concerned, most of the part has been covered by Sushant sir wonderfully. So I'll be very brief. In today's era, we are heading towards drug sensitivity-based therapy. So the regimen advised by NTEP has to be used by everybody. And the regimen is, as told by Sushant sir, is 2 HRZE and 4 HRE. Only for neuro and bone tuberculosis, the continuation phase is extended to 9 to 12 months. Now, the question here arises for commoners like me, why ethambutol is added? The ethambutol in continuation phase is added because of to counteract the monoresistance of INH, and also to decrease the amplification of rifampicin resistance. The dosages, most of the time we use NTEP's FDCs in our private practice. But at times we have to see, because most of the patients which come to me from pediatric orthopedics, Dr. Challawar, who is the only one in the region, most of the joint TB cases, they come to me. And in that case, they are already on the private formulations. The dosage has to be remembered by all the common pediatrician. The drug dosage is 10, 15, 30 and 20. So how do I remember 10, 15? Then you double it in the reverse way, 10, 15, 30 and 20. So whenever a patient comes to you, first job is to cross check whether the dosage is going appropriate or not as a private pediatrician. Few things in drug sensitive TB I would like to add. Never forget to add pyridoxine in the treatment. 10 mg per day is a must. And for DRTB, it goes to around 50 to 100 mg per day. In addition to that, I also add vitamin D for all these kids because there are few studies where it has been shown that vitamin D does help in management of the treatments. Offering HIV testing to all is a thing to be done, and that is the thing for drug sensitive TB, which I am following in my private practice. I have, as far as the NTEP FDC formulations are concerned, they are very good and they are very easy to use. They are safe also, and the PPSA in Nasik under Doctor For You agency, Mr. Shahid and all, they are just a phone call away, and they are helping all the private pediatricians in Nasik wonderfully. So this is as far as drug sensitive TB management is concerned.
Yes, thank you, Dr. Amol. And basically, what program is Vises is ki we are offering anti-TB drugs available under NTP also to the private sector patient. And as Dr. Amol have also mentioned that they are as good as private drugs available in the market. And in fact, you can see in Mumbai, almost 50% of private sector patients are taking anti-TB drugs from the public sector only because they are getting the results and they are acceptable also. Sometimes we do have issues with the availability of drugs, but we are offering these drugs wherever it is required by the private sector patients also. So that's good inputs from your side. So last question about the drug sensitive TB, I just want to have a comments from Dr. Sushant and others also. What are your thoughts on clinically diagnosed TB cases, role of Mantoux and empirical treatment? So I'll start with Dr. Sushant and then others can also add into that.
I think we have all discussed this. So
Yeah.
there is nothing like empirical treatment. So that word has to go out of our minds. So empirical treatment, 20 years back or maybe 22 years back when we were doing our undergraduation, where our boss used to walk into the rounds, इसको एक महीने का बुखार है, इसको AKT चालू कर दो. So it is not like that. So the word is now clinically diagnosed TB. So empirical TB, only Mantoux positive, anti-TB de do, X-ray अच्छा नहीं है, anti-TB, that all is out. So like we saw in the algorithm, you have a picture, you try to do a microbiological test. If after 2 attempts, the microbiological test is negative, you have a presumptive TB, you have a characteristic picture of TB, you start anti-TB treatment, wait for the culture, and it is labeled as a clinically diagnosed TB. It is not empirical. Pyridoxine with pyridoxine. Now, as far as Mantoux is concerned, Dr. Shilpa has very beautifully told us Mantoux is out of all diagnostic algorithms. So Mantoux's test need not be done for diagnosis of active TB. Till a few months back, Mantoux had a small role in the diagnosis of TB infection or a latent TB, what we say, that to 1 or 2 TU. Again, she has explained that we should not exceed 2 TU. But even that is out now because we have a new skin test that is a CYTB test or IGRA. So now even for diagnosis of TB infection or latent TB, we are not using Mantoux test. It is either an IGRA test or a CYTB test. So Mantoux is not there. ESR and all our supportive investigations we do not do. Just one additional point, because all the experts will agree here. There are some people, especially the adult physicians, are very much fond of doing ADA levels in pleural fluid and ascitic fluid, which we need to highlight here. Now, ADA does not help in pediatric tuberculosis. The message has to be very clear. Now, in adults, when there is a recurrent effusion, which is coming up in an adult patient, the dilemma there, diagnostic dilemma in adult chest physicians is to differentiate between a tuberculous and a malignant pleural effusion, where ADA definitely helps, because in tuberculous pleural effusion, ADA is very highly elevated, more than 60 is taken as a cutoff, and in malignant, it won't be elevated. But in pediatrics, to us, the dilemma is not between TB and malignancy. We hardly see any pleural or lung malignancies in pediatric age group. For us, the dilemma is to differentiate whether this is a tuberculous effusion or whether it is a partially treated bacterial effusion. And in these cases, our ADA does not help, because in both the cases, the ADA may be elevated. So never waste patients' money and even our time doing ADA level. Instead, do a pleural fluid aspirate, do a CBNet ultra, if you have a good ultrasound person with you, the easiest way we can have a microbiological diagnosis is taking a pleural biopsy from a thickening pleura and send that pleural biopsy for CBNet or ultra. That will give us a diagnosis. So that is, I think, the messages what from my side.
Yes, yes, because that is a very important message because we come across while visiting that some doctors do recommend empirical treatment for 1 or 2 weeks. So that should be discouraged and we should try to get the microbiological confirmation.
Yeah, sir. You said 1 to 2 weeks. Again, please
Yeah.
don't do all these things. If you want to treat clinically, it has to be 6 months.
Yes, yes.
There is no trial of 1 month or 2 months. You diagnose clinically, you give it for complete 6 months. Please don't give trial for 1 month, 2 months. I
Yes,
think it's
that-
a very good point, sir.
Yeah, that's very important point we want to cut across. Yes, Dr. Jitendra sir. you want to-
Sushant, I have a point. Some of the foreign students going to abroad and all are asking for IGRA test, so rather than Manto. So, what is your take on that?
No, IGRA needs to be done because they will not get admissions in the universities there. And even visa has a problem. So US, UK, they have a mandatory protocol to do an IGRA. So that needs to be done.
No, compared to means, can we extrapolate that to our diagnosing capabilities?
Yes. So, I mean, Mantu test now, even in the Western world, they are not advocating Mantu. They are advocating IGRA only. So we can do IGRA and it's a very simple test to do.
Okay.
Sushant, what is your view on stool gene expert, sir?
So stool gene expert is a good test. Okay. So it is yet not under the program. The reason being stool requires a little bit of pre-processing. Like for example, if we take a gastric aspirate or sputum, we directly put it in the cartridge and it goes into the CBNet machine. Stool requires a little bit of pre-processing. And that pre-processing method is being standardized right now. So it may come up into the national program soon. ICMR, NIRT at Chennai, the microbiologists, they are working on that standardization. कसं होतं ना ते स्टँडर्डायझेशन साठी लॅब टेक्निशियन लागतो. ओके हा स्टूल यू सेडिमेंट करा, त्याच्यानंतर ते सेंट्रिफ्यूज करा किंवा त्याच्यामध्ये काय ऍड करा, तर ते थोडं दॅट इज अ टॅक्सिंग प्रोसेस. दॅट इज वाय इट हॅज नॉट कम अप इन द नॅशनल प्रोग्राम. बट येस, इट्स सेन्सिटिव्हिटी इज कम्पेरेबल टू अ गॅस्ट्रिक ऍस्पिरेट. So if it is, I mean,
they are not accepting stool samples.
Who?
All the centers, they are not accepting stool samples.
Yeah, program will not accept,
yes.
But private lab you can send if you want. But we do it generally for very small babies. 6 महिन्याचं किंवा 8 महिन्याचं बाळ आहे, 1-2दा गॅस्ट्रिक ऍस्पिरेट घेतले and it is very not good for us also to put tube 10 times, then we send stool to a private lab. Program will not take because it is yet not under the program.
And even program don't have a ultra expert ultra. We have only normal.
Yes.
Yeah.
Sushant, Ramakrishna Paramahansa sir has asked one question. You said the CBNet can be negative, but liquid culture can come positive later. But can it be possible that CBNet is negative and sputum smear is positive?
Yes, if it is a NTM, it is possible. Because non-tuberculous bacteria, CBNet will only pick up tuberculosis, but NTM will be picked up on sputum. But again, a very rare scenario in pediatrics.
I think Sushant just comment on IGRA, like if he, because there are many practitioners who will do IGRA. So whether IGRA, it's better that if you tell to everyone that what do you mean by IGRA positive? Like how?
Like Dr. Shilpa said, कि many pediatricians are doing. Our question would be, why are you doing IGRA? Okay, if you are doing IGRA to diagnose TB, please don't do it. Okay, because it is not a test to diagnose active TB. I mean, the message is very clear. Like Jitu also said, students going abroad, they want to see whether there is a subclinical or a latent TB infection. Their IGRA is okay. If we have a pulmonary TB index case, there are exposed contacts, we do an X-ray test, there you can do an IGRA to see if there is a TB infection. But for active TB disease, never do an IGRA. It is not there under any guidelines. Now, when we do an IGRA, it is a blood test. So we take 3 to 5 ml of blood in an EDTA and send to the lab, and next day probably we will get a report. Okay, now it is a very specific test. Only if the blood contains antibodies to MTB, the test is going to come positive. So it has a utility, but only for TB infection. Don't do it for TB test. 1 month fever, you are suspecting TB, don't do IGRA. Because if it is positive, that does not mean it is TB. It could be because of a past exposure, anything. I mean, something like that.
Okay.
Sir, for TB meningitis, the rifampicin is said to increase the systemic clearance of steroids. So what is your view versus high dose steroid in first week and then tapering it to 2 mg per kg. Then because previously you said we are worried of like blindness and all.
So see, so there were studies previously which were done with 4 mg per kg and 4 to 6 mg per kg. But the problem with that high doses was in probably in second week the children were developing hypertension or some other problems. Now we have enough evidence that if you give by 2 mg per kg, it will still work. Even if rifampicin causes the clearance issues, it does not affect the activity of steroids. But we don't taper it. The thing is, we give it at 2 mg per kg for complete 4 weeks, 4 to 6 weeks, and then we taper. So it is not that you give with 2 mg per kg for 1 week and then taper and continue for a long time. We give the entire dose of 2 mg per kg for 4 to 6 weeks, and then over the next 1 to 2 weeks, bring down to 1 and then 0.5 and stop. Something like that.
Okay. Okay. Thank you, sir.
Yeah, it's good to have a cross questions between panelists. They're all experts. So, Dr. Amal Pawar, my request is, can we extend time?
Yes, sir. You can.
Yes. Yeah, because it's quite interesting discussions happening and all our experts are there. So I think we have done with the drug sensitive TB. Now we'll move on to the drug resistant tuberculosis. And again, I'll request Dr. Sushant to update all about the NTEP protocol, about how the drug resistant TB is diagnosed as per the diagnostic algorithm, and what are the treatment regimens or newer drugs available for treatment of drug resistant tuberculosis. Over to you, Dr. Sushant.
So drug resistant TB is, like I said, this is the general pediatric population which is sitting here. So I will not go into extreme details. Just in next 5 minutes, I will tell you when do we suspect drug resistant tuberculosis. Okay, because that is most important, right? So first and foremost, there are three or four conditions where we would be suspecting drug resistant tuberculosis. Okay, first and foremost, if we have a case of drug sensitive TB and he is put on treatment for drug sensitive, he or she is put on treatment for drug sensitive TB. At the end of 4 weeks or 1 month, if the patient is not improving at all or if the patient is worsening, then we would suspect that probably this is a case of drug resistant TB we are dealing with. More so if the initial point of starting was a clinically diagnosed TB. Okay, it may happen even in the drug sensitive TB, but more so if it was initially a clinically diagnosed TB. So at the end of 1 month of treatment of drug sensitive TB, if the patient is worsening or not improving, we suspect it is a DRTB. Second, if the patient is a loss to follow-up, that means we have started the patient on a treatment of drug sensitive TB. He took the medicines for at least 1 month or 4 weeks and he just vanished. Okay, there is no follow-up, and after 2 months the patient comes back still with signs and symptoms of active disease. This is the patient, again we would suspect that now the patient could have turned drug resistant. The third possibility is a relapse of TB, which means in a young age, say for example 3 or 4 years of age, the patient was treated for drug sensitive TB, a complete 6 months course or 8 months course, whatever. Later on in life, maybe in adolescence, 12 years or 14 years, he or she again comes up with active TB. Again, in this case, we would be suspecting drug resistant TB. And last, there are certain situations or conditions. For example, if a child is HIV positive, very high risk that it could be an upfront drug resistant TB we are dealing with. Second, if there is a definite history of contact with a drug resistant TB patient, close contact, for example, a family member, mother or father, or maybe an uncle who is staying in the same house. In fact, for such patients, if we have a clinical diagnosis and X-ray diagnosis of TB, we do a CB and it comes negative. In such kind of patients, we do not start the patient on drug sensitive treatment. We actually start the child on the same treatment which the primary contact is taking. For example, DR or MDR or pre-XDR, and then we wait for the culture of the child. So these are certain situations where we would suspect that our child could be a case of drug resistant TB. Now with the modern concept of doing an upfront CB-NAT for each and every sample and each and every patient, actually each and every patient we are screening for drug resistant TB, right? Because we are sending the sample and the result what we get is whether it is a rifampicin sensitive or rifampicin resistant. So when we talk about MDR TB, when do we label that specimen as an MDR is when that specimen is resistant to both isoniazid and rifampicin. This is a book definition. But when we see CB-NAT, okay, it gives us R resistance. Now R resistance is considered to be a surrogate marker for H resistance also, because 95 to 96% of R resistant samples are concomitantly resistant to isoniazid also. So it is a combined. So whenever our gene expert picks up R resistance, we treat it as a drug resistant TB. The second is a pre-XDR TB. So if an MDR TB additionally is resistant to any of the quinolones, like either a levofloxacin or moxifloxacin, it is labeled as a pre-XDR TB. And last is an XDR TB, a pre-XDR TB, that means resistance to HNR, resistance to quinolones. In addition, if it is resistant to either linezolid or bedaquiline or both, matlab either of the two or both, it is labeled as a labeled as an XDR TB. So these are the basic definitions. What happens basically is when the sample goes to the lab now, when we send a sputum sample, NAT is run. If the NAT shows it is a rifampicin resistant TB, which is picked up by a CB NAT, and if the smear is positive, or after the culture comes out to be positive, first and second line LPA both are run to see for the other drug resistance. That is whether it is a what is the status of fluoroquinolone resistance, injectable resistance, something like that. Now, even if the CBNAT shows rifampicin sensitive TB, that is RSTB, still a first line LPA is run either on a direct smear or on an indirect culture to pick up H resistance. Okay, because first line LPA gives us resistance to isoniazid and rifampicin. Now, this is a change in the algorithm which the program is following. The reason being, in India, we are reporting around 12 to 15, or I think it is a little more now, 15 to 18% cases of H monoresistant TB. And the regimen for H monoresistant TB is different. We don't give a drug sensitive treatment. That is the reason why, even if the CBNAT picks up rifampicin sensitivity, we do a first line LPA. And then, depending upon what resistance pattern we get, we would be treating. Now, when we talk about drug resistant TB treatment, there are three basic regimens. Okay, so one is what we can say the last part of the algorithm or the figure. If you see the H monopoly regimen, that means if it is an H monoresistant TB, it is very simple. Instead of H, so we are giving HRZE. Instead of H, we remove that H and give levofloxacin and complete the regimen for 6 months. That is the standard regimen. There is no continuation phase. There is no intensive phase. All the 4 drugs you give for 6 months. The another 2 regimens, one is a shorter regimen and one is a longer regimen. Now, I will not go into the details. Now, there are certain inclusion and exclusion criteria. What should be the resistance pattern to isoniazid, a limited pulmonary disease, non-extensive extrapulmonary disease. All these are and a patient of a MDR TB, not a pre-XDR or an XDR. All these few criteria would be eligible for a shorter regimen. Apart from that, for example, it is a pre-XDR, it is an XDR, it is an extensive pulmonary disease, bilateral pulmonary, CNS TB, miliary TB, abdomen TB, all of them are going to get a longer regimen. The difference between the shorter and longer regimen is shorter regimen goes on for a period of 9 to 11 months with multiple drugs, that is 6 to 7 drugs in the intensive phase, 4 drugs in the continuation phase, and the longer regimen is again a uniphasic regimen. There is no intensive phase and continuation phase. All these drugs go on for a period of 18 to 20 months. So I'll not go into the details because most of us don't treat it actually. Certain pointers when we are talking about drug resistant TB. One is always treat it in expert with a pediatrician who knows how to treat a drug resistant TB, because there's a different ball game altogether. The challenge is not only in the diagnosis. Once we diagnose, before even we think of whether to give a shorter regimen or a longer regimen, there is a whole list of pre-MDR TB investigations. We do CBC, LFTs, opthal evaluation, ECG, electrolytes, thyroid functions, so on and so forth, because most of the second line drugs are with side effects. So we want to know at baseline that all these parameters are normal. Then when we start the patient on treatment, we would be doing this at regular intervals. So the follow-up also is very important. At each and every follow-up, not only we check the adherence and the compliance and the drug dosages, but we also check actively for adverse drug reactions. Linezolid can cause neuropathy, it can cause pancytopenia, ethionamide causes hypothyroidism, quinolones can cause hepatitis, BDQ can cause hepatitis. So this has to be actively looked at, because children do not come up with symptoms. Adults are readily able to tell the symptoms if they are having any side effects. And the last but not the least, which is put in red there, never add a single drug to a failing regimen. Still in 2025, I'm sure all of the panelists who are sitting here would have experienced this. A drug sensitive patient started on 4 drugs, HRZE, the patient is still running fever at the end of 1 month or 2 months, or cough is still there, or X-ray is bad, levoflox is added to the regimen. This goes on in circulation, or maybe linezolid is added to the regimen. Never do all such things, because the most important thing is what we are doing. Okay, if it is a drug sensitive TB in the first place, we should know why it is not responding. If it is a clinically diagnosed TB, probably we are missing a drug resistant TB. Just by adding 1 or 2 drugs, number one, we are not going to do any good to the patient. In fact, we are going to propagate resistance to these 2 drugs, which are actually good drugs for MDR TB. So never add a single drug. If you think your patient is not responding, follow the protocol, reinvestigate the patient again, or if you are not in a position to do it, just refer the patient to a center who have all the facilities who will do detailed investigation. I think MDR-TB, this much is okay for the audience which is there here. Probable MDR-TB, like I said, there is nothing like probable MDR-TB. It has to have a microbiological diagnosis. Very rarely, even after all the attempts of doing multiple sampling, you're not able to get a microbiological testing, the patient is deteriorating, then this patient is referred actually to a DRTB committee. Now, all the medical colleges which are present in our country are nodal DRTB centers, and they are having DRTB committee. So the closest medical college or the nodal DRTB center which you have, wherever you are practicing, the patient is referred to that center. The committee reviews the clinical records, the clinical examination, all the reports, and the committee takes a decision that whether we should label this child as a probable case of DRTB and whether we should start the treatment. So as an individual pediatrician, we should never start any treatment for drug resistant TB just on probable basis, because like I said, it is a long treatment going on for months and there are a lot amount of side effects. So we should not be mistaken in starting the child wrongly on a drug resistant TB. Many a times we have had cases which were not TB at all. They were started on first line TB treatment, referred to us because the child was not responding at 2 to 3 months. This especially happens with abdomen TB, and we have got cases of Crohn's disease and ulcerative colitis and tropical enteritis being wrongly treated as TB. So drug resistant TB is not an empirical, or what I can say, a probable this thing. If you think it is resistance, if you're not able to achieve a diagnosis, refer it to a committee.
Yeah, absolutely. And as they said, in even the committee which is having at every medical college, we have to many times take expert opinion from people like you, because it's altogether a different ball game in pediatrics, and बीमारी से डर नहीं लगता है, साहब दवा से डर लगता है kind of thing is there in XTR TB. Yeah. So bedaquiline starting before that, so much work of all getting clearance from you and then starting. I think it is a very structured thing, and I think in private practice there is no time for the practitioner to do all these things in systematic way, and they should always take an expert opinion. Yeah.
So for managing pediatric DRTB, we have two special centers, like one is with the JJ Hospital with Dr. Sushant, and Wadia Hospital, where we do exclusively for pediatric. But in every DRTB center in district level, they are managing pediatric DRTB cases also. And it's actually a expert job, and some of the drugs, newer drugs like bedaquiline and delamanid, which we do use for pediatric patients also, they are not available in the market. So almost more than 90% DRTB patients, especially MDR and XDR, being managed in the public sector. So in that line, already Dr. Jitendra sir have mentioned it, but I'll still like to hear from Dr. Silpa or Amol. What is your experience of DRTB? The cases you have diagnosed, how they are being managed? Are you managing, or they are referred to the public sector DRTB center? And what is your experience about that?
We are not managing DRTB cases except mono drug like resistance, either INH or rifampicin. Otherwise, we are not managing DRTB cases because drugs are not available only. So we directly refer it to the DRTB center.
Yeah.
So even in Nashik, we are not managing DRTB, and fortunately here in this part of the world, there are very less DRTB pediatric cases reported. Even I spoke with the NTEP person in the morning. He said hardly 3 or 4 we have reported in last 2 or 3 years pediatric DRTB cases. And one case I have referred to Adia some 15 days back. After 6 months of therapy, the child was not improving, deteriorating. Fibrotic changes were developing in the lung. The child is at present in Wadia getting evaluated for DRTB, and yesterday night only I came to know that she turned out to be CGD, and they are now working on it. So we refer usually to Wadia all such cases in Nashik.
That's good. So all DRTB services or even DSTB services, they are available free of charge for public or private sector patients. So there is no discrimination. So wherever you want nearest centers, you can make use of that. And we need to try to diagnose the DRTB cases and put them on treatment timely. So I think this is okay with the, I think, drugs resistant TB cases. So we are coming to the last part of today's session. So diagnosing and treating TB cases is definitely important to reduce morbidity and mortality. But to reduce the TB incidence and to move towards the TB elimination, we need to have a preventive strategies in place. So currently we have one of the tool available for prevention is a TB preventive treatment. So again, I'll come to Dr. Sushant to update all about the TB preventive treatment protocols for the pediatric, especially less than 14 years. What are the strategies, what are the plans, and how you are following it? Over to you, Dr. Sushant.
Yeah, so just to simply brief the audience, so any TB preventive treatment is right now given under the program to all contacts of pulmonary TB patients. Okay, so if there is a pulmonary TB active case, especially sputum positive in the family or in a close contact, all the patients or the persons who are in close contact with that patient in index case have to be screened for TB. Now, what do we mean for screening? Okay, and this is one criteria. Another criteria is obviously HIV positive kids. Okay, that comes hand in hand. And so basically, it is not for contacts of extrapulmonary TB. It is for contacts of pulmonary TB. That is the first point. What do we mean by screening for TB? Is you screen with symptoms. That is the cardinal symptoms of fever, cough, weight loss, all these things. If the patient is symptomatic, any of the symptom is present, then we go ahead and do all the investigations. Whether you want to do an X-ray chest, sputum, whatever. If you are suspecting extrapulmonary, do an extrapulmonary investigation. And with all this, if you find active TB, we treat active TB. Okay. Now, if we don't find active TB, that means either the patient was not symptomatic, he is just a contact. Okay, and there were no active TB features found on clinical examination or on X-ray or anything. That means we are sure that there is no active TB in this patient. Then all these patients who are in contact with the pulmonary TB case get prophylaxis, right? So this is very clear. All the patients, by all, what I mean is all age groups. So initially it was up to 18 years, 5 years under. It is all gone now. Even all the adults in the contact have to get TB preventive therapy. Okay, so that is one thing we have to bear in mind. Every contact has to get a preventive therapy. Now, if you see the algorithm, they have arbitrarily divided it into less than 5 and more than 5. And what it says is, if the child is less, if the contact is less than 5 years, you start TB preventive treatment once you rule out active TB. If the contact is above 5 years of age, after ruling out active TB, if you have the facility, okay, that if is very important. If we have the facility, we try to diagnose TB infection. Now, how do we diagnose TB infection? Again, either by IGRA or a skin test, that is the CITB test. But if we do not have facilities to do an IGRA test or to do a CYTB or a skin test, then you counsel the patient, I mean the contact, to take prophylaxis for 6 months. It is very clear. Now, people would argue why this discrimination is made. There are two reasons for this discrimination. One, if we see the natural history of TB, okay, once the patient gets in, the contact gets infection, okay, once the infection is there inside the lung, either it remains dormant or it immediately activates. Now, all of the people who, all of the people who are carrying a dormant infection or a TB infection, as we go lesser in the age, that is under 5 or under 1 year of age, the chances of going into an active disease go on increasing. I'll give you an example. Suppose if there is an index pulmonary TB case in the house, there is a 8-month-old child, there is a 8-month-old child, there is a 3-year-old child, and there is a 12-year-old child. Okay, all these three are exposed to the TB infection. Okay, all of these three are exposed to the TB infection. An 8-month-old child has a 50% risk that he will go into an active TB. A 3-year-old child has a 25% risk that he will go into active TB, and a 12-year-old child or an adult has just a 5 to 10% risk that he will develop active TB. That is the reason for all under 5s, we do not waste time in looking out for TB infection, whether there is TB infection or not. If there is no active TB, just give prophylaxis. Now, why do we test the older ones? As you know, we as human beings are very much reluctant to doing anything with our bodies. Now, imagine you and me. Suppose tomorrow, if we are in contact with the active pulmonary TB patient. Now, this is a very stupid example because we all are in contact with TB patients because we are clinicians. But just to think, if we have a pulmonary TB index case and we are in contact, we do a TB screening. My X-ray test is negative. I don't have symptoms of TB. Tomorrow, if somebody tells me, look, you have to take 6 months of daily isoniazid for 6 months. I will say, why should I take any medication? I don't have any signs and symptoms of TB. My X-ray is normal. Why should I take the medication? So it is in these patients, if we do an IGRA or a skin test, and if it is positive, it helps the clinician to, give an extra bit of counseling to such patients that, look, although you don't have active signs and symptoms of TB, your test is showing TB infection. There is a chance that later on in your life, if your body becomes immunocompromised, this TB infection can turn into an active disease. Okay, and that is why you should take a TPT. So basically for above 5 years, or basically this is for adolescents and adults, it helps in counseling the patients to stick to the TPT. But otherwise, like we said, the program is very clear. If you don't have facilities to do a skin test or IGRA, please use all your counseling skills and give TPT to all the contacts, because TPT helps. There is ample evidence that the incidence of getting active TB goes down by more than 80% once the patient takes 6 months of TPT. And now we have options, like for drug sensitive contacts. Till now we only had 6 months of daily isoniazid. Now we have a beautiful combination of isoniazid and rifampicin, which is now available everywhere throughout the state. Now this combination tablet can be taken only once a week, and it is to be taken for 12 weeks. It is as easy as that, and in 12 weeks your TPT is complete. So any contact 2 years and above, we can give 3 HP. That is a 3 months of rifampicin and isoniazid once a week dose. Even for contacts of drug resistant TB patients, we do have TPT regimen. So if the index case is a pure MDR TB patient, that means the patient has to be proven fluoroquinolone sensitive. Then all the contacts, after ruling out active TB, we would be giving 6 months of levofloxacin. And if we have a H monoresistant TB as an index case, then again, after ruling out active TB, we would be giving 4 months of rifampicin to all the contacts. Whether you are giving TPT to drug sensitive contacts or drug resistant contacts, all those patients also should be given pyridoxine till the time they are on TB preventive therapy. So that is about preventive therapy.
Yes. So very well said. And
rifampicin and INH is a fixed drug combination.
Yes, FDC.
Yeah, it is available in FDC. And for skin tests, we have now CYTB test available, but currently it is recommended only for above 18 years individuals. Below 18 years, it is not available. Below 18 years, either you can rule out the active TB by X-ray symptoms, and in some cases, IGRA.
Actually, the talks are going on at the national level.
Yes.
Soon it will be open, because if you see, it is produced by Bharat Biotech. Okay, the test is done by Bharat Biotech, and the literature says that you can use it for children 1 year and above.
Yeah.
So the expert committee is now working on it, and I think very soon the program will approve it for 1 year and above. But right now it is for 18 years and above.
Soon it will be available. And it is like Mantus, but it has advantage than Mantus, because it will not have cross reactions with the BCG. BCG somebody have taken, CYTB will not come positive. It will come because of fresh infection.
Yes.
So coming to the last question to all,
the change which has happened in drug resistant tuberculosis contact preventive therapy is now, previously they used to say there is no prophylaxis available. Now the fluoroquinolone based, if it is sensitive fluoroquinolone, then 6 months, and otherwise monotherapy with INH is resistant, then rifampicin for 4 months. I think most of the pediatricians are not aware of this change, that we can still offer the prophylactic therapy for MDR TBs. Yeah.
So, Dr. Silpa and Dr. Amol, what is your experience? Have you recommended this TB preventive treatment to anybody, and they have used?
Not yet, sir. Not yet.
Okay.
In my center, actually, it's a nodal center where even adult pulmonologists are there. So I get quite a few patients of pulmonary tuberculosis where one of the family member has TB, and then we have to screen the child. And as Dr. Sushant Pane said, we do exactly the similar way, that we ask for symptoms, and if there are symptoms, then we screen them to rule out active TB, because that is very important. Then once we know that there is no active TB, then we are mostly 6 months of INH daily. But now I think this is a very easy option that weekly if we have to give this fixed drug combination, so we can use that also. But to most of the patients up till now, we have used a daily single dose INH therapy.
Yeah.
So
yeah, so as per the studies, almost the pulmonary patient, TB patients, household contacts, almost 71% of them are infected because of TB. And that's why TB preventive treatment is very much required in there. And if you give a TB preventive treatment, there are evidences that it will reduce almost 60% chances of developing active TB disease. So this is very important strategy to reduce the TB incidence rapidly. We don't have a very good vaccine. Maybe there are some work going on vaccination, but till that time, this is the one strategy we all need to get more aware about that, get ourselves convinced, then only we can recommend it to the patients and to our colleagues. So I think we are coming at the end of this panel discussion. So now it is open for discussion. So already I think we have a lot of questions in chat box. So Dr. Amol, can you guide it further?
Yes, sir. Thank you. Thank you for such a knowledgeable panel discussion. I think everybody has got to learn about the basics of tuberculosis and what to do when such patient come to their office practice. So I think many of the questions are answered. One question is, if hepatitis B positive and expectorant is there, but no fever and no change in weight, can we consider is that TB positive adult patient?
Hepatitis B fever and
yes, and expectorant is there.
Yeah, so then
no fever, no fever.
So if expectoration matlab cough is there, like we said, cough is a symptom of TB. So if it is there for more than 2 weeks, we have to investigate, do an X-ray test, do a sputum investigation, everything.
Yes.
Somebody has asked Sushant's WhatsApp number. So he's not available on WhatsApp most of the time, and he's immediately available on email. So write down his email ID. So officially also you will get a correct advice. Prashant, Sushant, you can put the
I
ID.
will put the official email ID.
Yeah.
Wait, I'll just put. Let me see.
Dr. Prachi Shirvatesi wants to ask, sir, sputum culture will do only TB culture or other bacteria culture in same sample?
Yeah, so if we are suspecting TB, okay, and a bacterial infection, we want to differentiate, then we can take the same sample and one part of it goes for MGI, I mean the TB, CBNet and all, and in the sterile container it goes for bacterial culture.
Next is a malnourished child from other state diagnosed as tuberculosis on basis of 5 TU units. Montauk's test took AKT for 4 months, discontinued for few days. What to do now? So 5 tuberculin.
No, so Montauk test should not be used. That is what we said.
Yes.
So somebody has asked before starting prophylaxis, should we extensively inducing the sputum and actively searching for the disease is mandatory, or we can start and then think of doing it later?
No, you have to search extensively. If the patient is having symptoms, you have to search extensively, do a X-ray, do a sputum examination. In fact, in such cases, we will say if X-ray is doubtful, we also do a CT scan. Okay, we don't advise CT scan to be done for each and every patient. But if X-ray is showing some doubtful shadow, the radiologist is not confirmed or the pediatrician is not confirmed what is this, and the patient is running cough or fever, you might as well do a CT because CT is a better investigation. Obviously, it would pick up some nodes or necrotic nodes, but we have to be very sure that there is no active disease because it is very it's a common sense in active disease. If we give one drug, it is going to worsen the situation.
Yeah. So someone has put a comment that nutritional rehabilitation also is one of the best way of incorporating in a TB management. Someone has written prophylactic treatment should be can we start in all extrapulmonary tuberculosis? So Sushant has already told that only for pulmonary TB we should start the prophylactic therapy. I think most of the questions are covered.
I have put the email ID in the chat box.
All the questions have covered. Anybody can raise their hand, and if we want to ask questions, we can take a few questions and then maybe close.
Questions.
So there is one important question, I think, to comment upon an indeterminate report of CBNet. Okay, so I'll answer that simply. So when we are doing a CBNet, okay, MTB detected, we get four options about the load of MTB. Either it is very high, high, low, and very low. Okay, and depending upon that, what we get is we are getting whether it is rifampicin resistance or rifampicin sensitive, right? Now if the what do the guidelines say is, if the rifampicin if the MTB detected is anywhere between very high, high and low, and rifampicin resistance is detected, right? This I'm talking about drug resistant. Rifampicin very MTB detected very high or low, medium or low, and rifampicin resistance detected, we take it as a valid result, and this would be treated as a case of drug resistant TB. The moment CBNet report shows MTB detected very low and rifampicin resistance detected, okay, these are the places where we would like to repeat a test, because the reason behind this is when the load is very low, bacterial load is very low, and the DNA load is very low, the interpretation of resistance which is done by the machine may not be the true representation of what is there in the patient's body, and therefore we would try to repeat a sputum sample. If two sputums pick up very low with a rifampicin resistance, then we treat it as drug resistant TB. Now sometimes it may happen that the machine reports MTB detected low or very low and rifampicin resistance indeterminate. It simply means, for this audience, it simply means that there was some processing error and the machine was not able to tell us the true status of rifampicin resistance. When it says indeterminate, the only thing which needs to be done is repeat the sample. Okay, that means if it is showing MTB detected low or very low and rifampicin resistance indeterminate, we have to repeat the sample. That is a clear guidelines, because it is not, we don't know what is the resistance pattern. Now there are exceptions. If, like I said, if we remember what we talked about in drug resistant TB, suppose if the test shows very low rifampicin resistance detected, I said it has to be repeated. But if this child is in contact with the MDR TB person, like for example a mother or father who is taking an MDR TB treatment, then we don't waste time in repeating, because we have a definite source in the house who is who is on MDR TB treatment. This child specimen has shown that it is detected, though it is very low, but rifampicin resistance is detected, and then we would not repeat a sample. These are the only situations where we will not repeat. Otherwise, anything which is reported very low needs to be repeated. Anything which is indeterminate needs to be repeated. At the end of IP, smear shows positive and not zero. How to proceed? So at the end of IPC, this problem generally does not arise in pediatrics, because most of the times pediatrics are smear negative. Now at the end of intensive phase, if the smear is showing, if the smear is positive, that is the reason why I said in follow-ups, we always do a smear and a culture. If the patient is clinically responding, if the patient, I mean, weight gain is present, we wait for the culture report to see if the culture is positive or negative, because a positive smear can, even a dead bacillus can give a positive smear. Okay, so we don't know whether the smear which is showing is a dead bacillus or active bacillus. The only way we can say that the patient is responding, for example, if at the beginning of therapy a smear was 3+ or 4+, and now the smear is 1+, the patient is responding, that means the load has gone down. Okay, but if the smear is positive, if the patient is clinically responding, we look at the cultures. If culture is positive, that means the patient has not responded. Otherwise, we don't do anything.
So if there are no questions, I'll just
Actually,
share.
I have
Yeah.
one issue because there are a lot of government authorities here on tuberculosis. Like we have had many disseminated TB cases and miliary cases and bronchial cases, fibrocavitary cases, where CB-NAT is strongly positive, but I am yet to have MGIT culture positive. I mean, I do not understand why such patient sample also MTB culture is always negative. So I actually want you to do something for Nagpur like center, like I don't know, because this is just impossible that I'm yet to see a MGIT culture positive.
So Nagpur as a IRL, na sir?
Yeah. Nagpur has a IRL, that is a certified lab. Even it is a NABL accredited
What is
certified
going wrong?
laboratory.
Because
So
madam has called me so many times in distress.
yeah,
How is it
yeah,
possible that CB net is positive and culture is coming negative, which is very unlikely. It happens, but it happens very unlikely. But
yeah.
madam's experience is all her samples are CB net positive, but culture is coming negative, which is a little doubtful. It should not happen that way.
Definitely, we'll discuss with CDC director of Nagpur about this issue, and we'll get back to it. Yeah. So yeah, before any questions further, I'll request Dr. Bhalerao sir to share few of our expectations from the IAP after this meeting, because from NTP side, we have some expectations to way forward what we need to do further and how we can strengthen this collaboration. So over to Dr. Bhalerao sir.
थँक्यू सर. ज्या काही एक्सपेक्टेशन्स मला प्रोग्रामच्या अनुषंगाने आहेत तर त्या 2-3 आहेत. तर त्या मी या ठिकाणी सांगतो. आत्ताचं जे आपलं डिस्कशन नक्कीच अगदी अकॅडमिक लेवलवर झालेलं आहे आणि जे कोण डेलिगेट्स आहेत नक्कीच त्यांना त्याचा फायदा झालेला आहे. परंतु असं असलं तरी हे वन टाइम होणं अपेक्षित नाही. त्याचं असं वारंवार जर का आपला रिफ्रेश जर का असं ट्रेनिंग किंवा CME झाली तर निश्चितच डिस्ट्रिक्ट लेवलला सुद्धा त्याचा फायदा होऊ शकतो आणि परिणामी जे डिस्ट्रिक्ट लेवलला जे आमचे डिस्ट्रिक्ट TB ऑफिसर आहेत किंवा त्यांची टीम आहे, सिटी ऑफिसर कॉर्पोरेशन लेवलला आहेत त्यांची टीम आहे, तर त्यांना सुद्धा याचा फायदा होऊ शकतो. तर संबंधित संयोजकांना विनंती राहील की असे CMEs वारंवार घेऊन आपले एक्सपर्ट कॉमेंट्स किंवा आपले एक्सपर्ट नॉलेज जर का त्यांच्याशी शेअर झाले तर निश्चितच प्रोग्रामला त्याचा फायदा होऊ शकतो. दुसरं याच्यामध्ये की जे काही आपल्या TB केसेस आहेत तर त्या टाइमली नोटिफाईड होणं गरजेचं आहे. आपल्या सगळ्यांनाच माहित आहे की NTEP अंतर्गत निक्षय पोर्टल आहे आणि निक्षय पोर्टलचा जो डेटा असतो तो स्टेट लेवलला, नॅशनल लेवल इव्हन इंटरनॅशनल लेवलला तो व्हॅलिड धरला जातो आणि बिईंग अ TB नोटिफाईड डिसीज त्यामुळे प्रत्येक जे कोणी आपले सर्वजण मंडळी आहात, डॉक्टर्स आहात, तर आपण ते केसेस नोटिफाईड होणं टाइमली हे प्रोग्रामची डिमांड आहे. दुसरं मायक्रोबायोलॉजिकल कन्फर्मेशनच्या संदर्भामध्ये सुद्धा ज्या काही आपल्या आता सर मॅडमने पण सांगितलं की कधी कधी आपल्या कल्चरला आणि त्याला इश्यू येतात आहे, त्या वेळोवेळी आपण त्या संदर्भामध्ये एकमेकाशी आपण जर का कोऑर्डिनेशन ठेवलं तर निश्चितच मायक्रोबायोलॉजिकल कन्फर्मेशनच्या संदर्भामध्येही आपल्याला त्याचा फायदा होऊ शकतो. कारण क्लिनिकल तर डायग्नोस होतच, त्याबद्दल वादच नाही, परंतु ते प्रपोर्शन परिणामी कमी असावं अशी प्रोग्रामची अपेक्षा आहे. फोकस्ड मायक्रोबायोलॉजिकल कन्फर्मेशनला आहे, कारण की त्याला आपण गोल्ड स्टँडर्ड टेस्ट असं आपण त्या ठिकाणी म्हणत असतो. ड्रग रेजिस्टन्स सुद्धा आपल्याला रूल आउट करणं गरजेचं आहे, कारण की आजचं जे प्रपोर्शन आपण जर का पाहिलं तर साधारणतः 9 ते 10% आपला ड्रग रेजिस्टन्स आहे. विशेषतः मुंबई आणि मुंबई अर्बन एरिया आहे तर त्यामध्ये हा वन ऑफ द इश्यू आहे की जो प्रोग्रामसाठी चॅलेंजिंग आहे. तर त्यावर सुद्धा आपण फोकस करणं अपेक्षित आहे, गरजेचं आहे. स्टँडर्ड ट्रीटमेंट प्रोटोकॉल्स हा एक नेहमी डिबेटेबल इश्यू असतो. जे प्रोग्रामच्या याच्यामध्ये निश्चितच जे काही फील्ड लेवलवर, पब्लिक हेल्थ लेवलवर जे काही चालतं ट्रीटमेंट तर तो त्या ठिकाणी फॉलोअप होतो, परंतु आपण सुद्धा या संदर्भामध्ये जर का आपण त्याच्या संदर्भाची काळजी घेतली तर निश्चितच स्टँडर्ड ट्रीटमेंट प्रोटोकॉल आपण त्या ठिकाणी फॉलोअप करू शकतो. सर्वात महत्वाचं म्हणजे ते आता नॅट टेस्टिंग किंवा जे नवीन ऍडव्हान्स टेस्टिंग आलेलं आहे, NPY जे काही अनुदान अगदी आपल्या सर्वांसाठी पण आहे, तर ते फ्री सर्व्हिसेस हा वन ऑफ द कॉम्पोनंट आहे. कारण की आपल्या सगळ्यांना माहिती आहे की TB फ्री इंडियाचा जो शेवटचा जो काही गोल आहे की ज्याला आपल्याला 0 कॅटास्ट्रॉफिक कॉस्ट आणि बाकीच्या इतर ज्या गोष्टी आहेत तर याचाही बेनिफिट आपण सगळ्यांनी आपणही घेतला पाहिजे आणि आपल्या पेशंटसाठी, रुग्णासाठी सुद्धा आपण देणं गरजेचं आहे. आणि सर्वात महत्वाचं म्हणजे सध्या अर्बन लेवलला TPT म्हणजे TB प्रिव्हेंटिंग ट्रीटमेंट जो आपण हाऊसहोल्ड कॉन्टॅक्टसाठी सध्या सुरू आहे आणि 180 डोस देणं की नुसतं INHचं आपण जे काय 2 वर्षापूर्वी सुरू केलं होतं त्याला ॲडव्हान्स राहणं, त्याला मेंटेन करणं अवघड जायचं, परंतु आता 3HP मुळे या रेजिममुळे आपल्याला ते सोपं झालेलं आहे आणि 3च महिने आपल्याला एकूण 12 डोस ते घ्यायचे. तर याचंही प्रॉपर प्रोपोगंडा, त्याचं प्रॉपर IC आणि पेशंटची काउन्सिलिंग किंवा त्यांच्या नातेवाईकाची काउन्सिलिंग होणं गरजेचं आहे. याच्यामध्ये आपण पॉझिटिव्हली कॉन्ट्रीब्युट कराल एवढी मी प्रोग्राम कडून आशा व्यक्त करतो, आणि जे एक्सपेक्टेशन्स जे आपल्याकडून आहेत तर ते या ठिकाणी मी जे 2 सांगितले त्याच्यावर आपण काम कराल अशी आशा व्यक्त करतो. धन्यवाद. ओव्हर टू येवले सर.
थँक्यू सर, थँक्यू फॉर युअर लास्ट कमेंट्स. सो मला वाटतं खूप छान डिस्कशन झालेलं आहे, अँड मोस्ट ऑफ द डाऊट्स वी हॅव क्लिअर्ड. आणि जे काही स्टँडर्ड प्रोटोकॉल्स आहेत फॉर डायग्नोसिस, ट्रीटमेंट, टीबी प्रिव्हेंटिव्ह ट्रीटमेंट, हे आपण सगळ्यांशी शेअर केलेले आहेत. सो लास्ट वन पॉईंट, निक्षेप पोषण योजनाबद्दल सगळ्यांना माहीत झालंच असेल की प्रत्येक टीबी पेशंट डायग्नोज झाल्यानंतर त्याच्या न्यूट्रिशन सपोर्टसाठी प्रोग्रामकडनं ₹1000 मंथली त्याला दिले जातात टू असिस्ट द न्यूट्रिशन सपोर्ट. तर त्याच्यासाठी पेशंटना बँक डिटेल्स देणं हे अत्यंत आवश्यक आहे. आता लहान मुलामध्ये त्यांचं स्वतःचं बँक डिटेल्स नसणार आहेत, त्यामुळे त्यांच्या पॅरेंट्सचं पण ते बँक डिटेल्स देऊ शकतात. आणि आपण ज्यावेळेस हे बँक डिटेल्स आपल्याकडे मिळतं प्रोग्रामकडे, तर त्याच्यानंतर डायग्नोसिस झाला पेशंट की लगेच त्याला इमिजिएटली ₹3000 ट्रान्सफर होतात, आणि 3 महिन्याची ट्रीटमेंट कंप्लीट झाल्यानंतर परत 3000 दिले जातात. सो इनिशियली फर्स्ट 3 मंथ्स मध्येच त्याला ऑलमोस्ट ₹6000 मिळतात टू टेक केअर ऑफ द न्यूट्रिशन. आणि इफ द पेशंट ट्रीटमेंट इज एक्सटेंडेड बियॉन्ड 6 मंथ्स, देन तिथून पुढे मंथली ₹1000 दिले जातात जोपर्यंत त्या पेशंटची अँटी-टीबी ट्रीटमेंट चालू आहे. So these are different provisions available under the program to reduce their out-of-pocket expenditure, and patient should complete the full course of treatment. They should not stop the treatment in between because of the issue of budget availability with them. आणि सगळं काही ड्रग रेजिस्टन्स वगैरे वेळेवर त्यांनी ते रूल आउट करता आलं पाहिजे. सो ओके, दॅट्स ऑल फ्रॉम माय साइड. नाउ ओव्हर टू डॉक्टर गिरिजा फॉर द कन्क्लुजन.
येवले सर, मला एक प्रश्न आहे. जर प्रायव्हेट प्रॅक्टिशनर्सनी रिपोर्ट नाही केली तर काही हे आहे का त्यांना?
Yes, as per the Gazette of 2018, as per the IPC rule, there are some financial कुछ काही फाईन पण आहे आणि इवन इम्प्रिझनमेंट पण प्रोव्हिजन्स आहेत त्याच्यामध्ये. बट ॲज ऑफ नाऊ जनरली वी आर नॉट गोइंग इन टू दॅट. बट as per our Commissioner Health sir, he strictly mentioned that there are some hospitals who are not notifying. So we are going to start giving notices to them, and after 1 or 2 notice, if they are not following this, then definitely there will be legal actions against them. So there is a provision, but to begin with, we don't want to go into that kind of situations. We are trying to have a good coordinations in a healthy things instead of going into the punishment and all those things. But definitely government has that things in their hand. आणि जर फारच कोणाकडनं incorporation मिळाला तर then that will be used. But we don't want to come to that situation.
That is rather our responsibility to notify
Yes.
the cases.
Yeah, it's everybody's responsibility to follow this thing. Yes, sir. Dr. Sanjay sir, you want to say something? You can.
Yeah, wonderful insights given by all the panelists, and every question was very well answered. I think many people were having so many questions. I think they are really updated after this panel discussion, and most of their queries are solved because they were answered in a very single line of questions. They were answered by all the panelists in a very efficient way, so that here onwards it will become easy for them in their practice, and it is going to have will be of a great help to them so that they can diagnose, and they can diagnose the pediatric tuberculosis patients efficiently and report them, as well as having a proper treatment the way all the panelists have told them. And I hope it is going to enrich their knowledge, and they will definitely get benefit of this panel discussion. And in the future also, we'll, after few months, again we'll organize this particular session. The people who have missed this opportunity, they might join in that later session also.
So we'll definitely have such kind of sessions in future also. But we encourage to have sessions at the district level also, so that we can have a better coordination at that level for the services.
Definitely.
Yeble sir, one question from someone like pathologists are not allowed to report on Nikshay at their CDNAT reports. Is it so?
Yeah, actually, everybody is allowed, but generally what we say that there should not be duplication of the cases. Like practitioner who have already notified case and sample has gone to the pathologist and they have again notified it. So there will be duplication. So our PPSA agency or NTP staff, they collect the information from them. If that case has not already been notified, then they will notify that case. So that's why generally we hold the data from chemist and pathologist or laboratories, not to directly enter into the NICSHI. And if that case has not been notified by a practitioner, then we do consider that case also. So I think two more hands are still Dr. Vijay Bhave. Oh, yeah. Ram Kishan.
Yeah, I have taken his question.
Okay.
Vijay, you can type in the chat box. We will ask, sir.
Okay. If there is no question or any other comments, then over to Dr. Girija.
Thank you so much. As we are concluding our webinar today, so I just would like to thank everyone during this discussion. Firstly, I would like to thank Dr. Vasant Khalatkar sir, National President of Indian Academy of Pediatrics, because he has given his insight remarks during our session. I also thanks Dr. Sanjay Pakmode sir, President of Indian Academy of Pediatrics, Maharashtra, who has supported us, and even the Dr. Amol Pawar sir, Secretary of IAP Maharashtra, who has really coordinated well for this program, because while we were discussing about how to take this forward, or how many will be the participant, like that, we have many questions. So he has lead all these webinar discussion and supported a lot. So thank you so much, sir, for your guidance and support for this program. I also thanks mostly and important person who is always guide us for the sensitized to the different association, Dr. Sandeep Sangre sir, Joint Director of Health Services, TB and Leprosy, Maharashtra. He would like to actually discuss with you, but some emergency meetings he could not able to do. But yes, thankful for him about his guidance for the program. I also thankful to Dr. Nitin Bhalerao sir, ADHS Maharashtra, who provide the he built the context of meeting, and even provided the expectations what we need from the IIP Maharashtra. Mainly, I'd like to thank the panels who had discussed a deep discussion, because we had previously conducted different meeting with the different association like IMA, FOGSI, and even NEMA. So that time the discussion is in that the presentation and the question answer. But here the panel discussion give a different kind of context, even the what kind of practices held in the field, and even what kind of how to do in the field, that has deeply discussed during this session. So I thankful to Dr. Sushant Mane sir, Associate Professor and Nodal Officer of JJ Hospital, Mumbai. He had given good context and even presented a very deeply about the NTP program. I also thankful Dr. Shilpa Hazare ma'am, Pediatrician Pulmonology of Nagpur, Dr. Jitendra Gavane sir, Professor Head Pediatric PICU, in charge MGM Medical Navi Mumbai, and Dr. Amol Murkute sir, Assistant Professor, Vasantrao Pawar Medical College, Nasik, who has built the context and provided the insights about the field realities. So thankful everyone, and yes, of course, without all the participants and the pediatricians of Maharashtra, state and state and district bearers of office bearers of IIP, those who has attended thorough the all meeting. So thankful to them. I also thank to State TB Office, WHO consultant, and my colleagues, State Technical Support Unit members for this session. Thank you so much. With the permission of State TB Cell and IIP Authority,
There is one, ma'am, there is one question. Someone wants to talk, Dr. Ramkishan. So please unmute and talk, sir. Dr. Ramkishan. I think
Madam has to make him post. He has an
Yes, yes, sir. Permission given. Permission given.
हॅलो.
yes sir.
हा सर, माझं एक 2-3 प्रश्न होते. एक तर पॅथॉलॉजिस्टला आधी ते अलो करत होते आणि बऱ्याचदा केसेस जे आहे क्लिनिशियन हे करत नाही, नोटिफाय करत नाही आणि पॅथॉलॉजिस्टला आता 1 वर्षातच ते करू देणार. तर त्याच्यासाठी काय सोल्युशन आहे निक्षेवर?
सर कुठल्या डिस्ट्रिक्टचा हा इश्यू आहे?
हिंगोलीचा आहे सर. आणि माझ्याकडे सर महिन्याला कमीत कमी 5 ते 6 पॉझिटिव्ह येतात स्पुटमचे आणि एक्स्ट्रा पल्मनरी जे आहे एडीए रेस किंवा हे कमीत कमी माझ्याकडे 10 तरी असतात सर.
ओके.
आणि दुसरा एक आहे सर की
ADA
दुसरा एक प्रश्न आहे सर.
this is a decision
ठीक आहे
of a
सर.
clinician to decide whether that is a TB or not. So त्यामुळे
ठीक आहे सर.
बऱ्याच गोष्टी आपण त्यांच्याकडे ठेवतो आहोत. तो जर पेशंट ऑलरेडी त्यांच्याकडे नोटिफाय नसेल झाला तर नक्कीच तुमच्याकडल्या आयडीने तो
नाही सर, आता निक्षेवर होतच नाही सर. माझ्या आयडीवर निक्षेवर नोट होतच नाही. माझे कमीत कमी महिन्याला 15 पॉझिटिव्ह राहतात. स्पुटम 5 पॉझिटिव्ह असतात कमीत कमी आणि ईपीचे 10 तरी असतात सर. आणि दुसरा प्रश्न हा आहे सर की स्पुटम मध्ये पॉझिटिव्ह आहे तरीही सीबी नॅट मध्ये स्पुटम निगेटिव्ह आलेला आहे, तर ही कोणती कंडिशन आहे सर अशी?
जसं आता ऑलरेडी डॉक्टर निशांत आपलं सुशांतने सांगितलं की NTM मध्ये हे प्रॉब्लेम होऊ शकतो की मायक्रोस्कोपी पॉझिटिव्ह आहे परंतु सीबीनॅट निगेटिव्ह आहे. इट इज इन द कॉन्टेक्स्ट ऑफ NTM.
टिपिकल मायक्रोबॅक्टेरियामध्ये पण एकदा पस आलेलं आहे माझ्याकडे, पॉझिटिव्ह होतं आणि CSOMचं होतं आणि ते तिकडे निगेटिव्ह दाखवलं होतं त्यांनी. मग क्लिनिशियन थोडंसं गोंधळात पडले होते.
सो ही सगळी
NTM म्हणजेच एटिपिकल मायकोबॅक्टेरिया. सो द अदर नेम फॉर एटिपिकल मायकोबॅक्टेरिया इज नॉन ट्युबरक्युलस मायकोबॅक्टेरिया.
फक्त ते निक्षेचं पहा सर, निक्षेचं होईन गेलं हिंगोलीला.
ओके सर, विल चेक इट. पण जसं आता म्हटलं ना की जसं बऱ्याच गोष्टी तुमच्याकडे रिपोर्ट येतो परंतु तो TB आहे की नाही हे डिसाईड करण्याची ऑथॉरिटी इज कन्सर्न ट्रीटिंग फिजिशियन. तर त्यामुळे जनरली आपण त्या ट्रीटिंग फिजिशियन कडनं ते नोटिफाय करून घेतो. तुमच्याकडनं इन्फॉर्मेशन कलेक्ट केली जाते अँड टू अवॉइड एनी डुप्लिकेशन्स तो डेटा मॅच करूनच मग ते नोटिफाय केलं जातं.
नाही सर, पण माझ्याकडे डाटा घेण्यासाठी कोणीच येत नाही आणि कलेक्टर साहेबांच्या पूर्ण क्लिअर कट गाईडलाईन्स आहेत की तुम्ही नोटिफाय करा आणि डाटा घेण्यासाठी कोणीही येत नाही.
परत एकदा तुमचा डिस्ट्रिक्ट मला नाही समजला, कुठल्या डिस्ट्रिक्ट मधलं?
हिंगोली
का? हिंगोली प्रॉपर टाउन मध्येच आहात ना सर?
हो सर, शहरामध्ये हिंगोली.
लॅबोरेटरीचं काय नाव सर तुमच्या?
नाथ गजानन पॅथो मायक्रो लॅब. 23 वर्षापासून प्रॅक्टिस करतो सर हिंगोली.
ठीक आहे. आपल्याकडे तिथं PPSA पण आहे, सो विल इन्फॉर्म देम.
ठीक आहे सर, चालेल. ओके, थँक्यू व्हेरी मच.
थँक्यू सर.
So thank you all. So now we can close the session.
Yes.
Thank you.
Thank you Rajabu sir. Thank you Nitin Bhalera sir. Thank you all.
Yeah.
Thank you.
Thank you, Lisa. Thank you. Thank you, Sushant sir. Thank you, Jitu sir.
Thank you,
Shilpa ma'am.
Thank you for the opportunity.
Thank you, Girija ma'am.
Thank you, sir.
Thank you, Bhalera sir.
Yes.